Okay, good evening and welcome to our web meeting. It's a third monthly web meeting, and this is focused for the residents, by the residents, and these are being initiated, mediated, continued with the support from the trainees throughout the country. And for the last two meetings, we had a wonderful experience, and they have put their all thoughts and wisdom in association with the young teachers along with the wisdom of the senior teacher, and that's a very successful meeting and a very productive meeting. This month is the day one for the third leg meeting, and we'll be having a best of the best minds in reference to landmark papers. First on rheumatoid arthritis by HOD, Chief of Rheumatology, Clinical Immunology from CMC Vellore, Professor John Matthew. And all of you know John. He's a wonderful guy with a lot of contribution from his institute. Next would be on myositis, Dr. Latika Gupta from SGPGI. She had a lot of scientific contribution globally on this topic. And third component is on scleroderma, and no other than Dr. Padmanabha Shenai. He is at present one of the key person in Indian Rheumatology Association Executive Committee, and he has an immense interest in scleroderma for last several years with a lot of international contribution. And Dr. Tamir Chelbam from same Madras Medical College. Yes, kindly agreed to chair the session, so it will be an additional bonus point for us. So let's start.
Today, rheumatology. I am supposed to chair the session for today, and equally thankful to Dr. Arya who has contacted me a few months back itself and got my assurance for the meeting. Because now, talk would be on. And it's very nice that the webinar is going on every third Saturday, and it's the biggest success for our national president, Dr. Alandu Ghosh. Let's give a big, we cannot clap now, but anyhow, it's our honor to get pleased by his presence, and he's always a dynamic person. I know him as a DM student from 2004 onwards. I have watched Professor. He has been very articulative, dynamic, and he is always goal-oriented. That's what I like from him. Always goal-oriented. He doesn't bother about the triviality. Triviality, he never gives importance. That's a good aspect of that. And first of all, we have got 3 sessions, and I would like to the respective speakers to adhere to the timings. And the first session would be by Dr. Professor John Matthew. Good evening, John Matthew. Both of us are equally known to us for the past 30 years or so. So when I was doing at Stanley MD General Medicine, when I completed, John joined, and both of us know, even though there was no contact, we know each other for more than 3 decades. And he had been examined to us in the last session. And he is one of the most dynamic and scholastic persons that I have ever met. And with his immense guidance, CMC Vellore is started excelling and continued to excel. It was excelling under Professor Devash Danda, and I think John Matthew is carrying on the further works, and he is now today going to talk on landmark inspection, and John is always focused. He talks less and does more. That's what I have an impression on John, and he listens more than talking. He likes to listen more than talking. He falls in that category. And today he has to talk more. So, please, sorry for putting in an embarrassing situation. So please have your talk on the landmark papers in RA this year. Over to John.
Thank you, Dr. Tamil Selvan, for the kind introduction. At the outset, let me thank Professor Alagintu Ghosh, Dr. Sapan Pandya, Dr. Chadobadhyaya, and all my co-panelists, Dr. Alagintu and Sapan, particularly for organizing this meet and taking giving rheumatology a great lead in this country. Thank you for giving me this topic. So I had a quick chat with Dr. Ghosh, and he said probably we can go for last 5 years of landmark papers in rheumatoid arthritis. So how do we decide which are the landmark papers? So obviously something which has an impact on the way we practice management of rheumatoid arthritis, where research in rheumatoid arthritis go forwards, or the way we understand the disease is what I thought landmark papers would be. And so I thought we'll stick on to probable looking at the landmark papers in the past 5 years. So then I got this article from Medicine 2019, where the top 100 cited articles on RA. This is a bibliometric analysis. And the citations for each of these 100 articles varied, with the topmost article having 12,000 citations, where the 100th article having 500 plus citations. And these were articles published between 1985 to 2014 in 24 journals, of which Arthritis and Rheumatism have the highest number of articles, followed by NEJM, followed by Lancet, ARD, Nature, etc. And if you take the first 100 cited articles, United States had the contribution in 58 of them, and United Kingdom in 42. And of the 100 top cited articles, 55 of them were on clinical studies, 17 were review articles, 4 were meta-analysis, 10 were on clinical guidelines, and 14 were on basic science. So just ask your attention on figures B and C, and of the clinical studies, obviously as expected, the highest cited were RCTs, followed by prospective cohort study, and so forth. And about the content of the articles, as we all would expect, evaluation of drug therapy had the highest number of articles, followed by pathogenesis of disease, followed by risk factors, then epidemiology, disease activity studies, or classification criteria. And where do we stand in this? Actually, this is how different countries have contributed to these studies, of which maybe you have Japan and China from Asia with some contribution from South Korea and Singapore. Otherwise, it's all Caucasian contribution. Of course, there is Argentina also there. So most of the world doesn't have much of a contribution in the first cited articles. Now, another way to look at it is, who are the authors who contributed most in these first 100 cited articles? Dr. Smolen had a citation about close to 4,500 plus, followed by Feldman, Weinblatt, Ravidarmani, and Elliott. So these are the names which we commonly see. These are why the names which we commonly see in articles on rheumatoid arthritis. And just, I don't want to go through this slide, but these are the highest cited articles. The first one is the 1987 classification criteria for rheumatoid arthritis. And number 10 was Dr. Ravindra Maini's article on infliximab versus placebo in rheumatoid arthritis. And these are the other 10 articles, so the first 20 articles. Just a word about bibliometrics. It is analyzing the scientific production quantitatively and the thematic evaluation of a given research field, like thematic evaluation of rheumatoid arthritis. And then you have the performance analysis. It can be done in two ways. One is performance analysis and science mapping analysis. Performance analysis meaning measuring the scientific production with indicators, which could be production indicators, impact indicators based on citations, or based on the impact of the journal, and then science mapping analysis. And I'm not going to the details of bibliometric indices, just these are the things which you look at them. And science mapping software tools, there are many science mapping software tools, of which SITNET Explorer, SkyMat, WASPviewer these are the freely available science mapping software tools from which we can look at which are the journals or the impact of the journals and how important it is. And so for rheumatoid arthritis, that's the only article I found, but we have not gone through these processes. And we know about the citation metrics where Google Scholar has the highest citations followed by Web of Science and Scopus. And but as all of us know, many of us access download articles, share articles on WhatsApp, IRA website, different websites, even on Facebook or whatnot, Twitter. And actually all these contribute to the scientific content or the impact of an article. And which these doesn't come in when you look at just at the citations. So this is an article in JAMA 2017, where the index called altmetric is taken into account, and the circle you see here is called an altmetric donut, and each of these colors indicates different methods of impact of that article on the society, which may be just a Wikipedia to Google to Twitter to downloading. So, and the width of each of these color depends upon how much number of times it has been downloaded or whatever has been done with the journal. So there are about 2.5 million scientific articles produced every year. And this 2.5 million doubles every 9 years. So you understand the extent of the impact of the scientific articles. And then you have a score called the altmetric score for each article. And ideally, when you ask for landmark papers of rheumatoid arthritis, you should look at the altmetric score and then say, these are the 10 papers or these are 15 papers I'm going to talk about. But this has not been done for rheumatoid. Closest it has been done for is what I showed you, the paper which I showed you before in Medicine, 2019. It has also been done for psoriatic arthritis. Now, going to different areas of rheumatoid, the first is a study in ARD 2014, which showed the global prevalence of RA, which is like 0.24%. And the data from India, which we have, is by Dr. Malavia in 1993, which said it's 0.75%. So that is regarding epidemiology of RA, which we have till now. And I think many of you would be familiar with the KOMORA study, which looks at the prevalence of comorbidities in RA and evaluation of their monitoring. This is an international cross-section study, which was published in 2014. After that, what happened? So many of you would be aware of the Corona US registry, where people can willingly join the registry and enter their data. Even individual practicing rheumatologists can enter their data, and they have the Corona US registry. And the Corona has something called the Corona International Registry, where patients from 10 ex-US, outside US participating countries are included, of which they are grouped into regions like Eastern Europe, Latin America, and India. And fortunately, from India, we have Dr. Malavia, who is part of the Corona International Registry. And they looked at this is an article published in Clinical Rheumatology 2018, which looked at the prevalence of cardiovascular disease and major risk factors in patients with RA. And the study says that the standardized one outcome which the study says is the standardized prevalence of any prior cardiovascular event is least in India compared to other countries in the cohort. And Eastern Europe is almost 7 times that of India. And one of the remarks in that paper says that Indian rheumatoid arthritis patients have the healthiest profile with lower prevalence of family history of early MI or stroke, lowest BMI, and almost exclusively non-smokers. We know our women don't smoke. Low standardized prevalence of dyslipidemia and hypertension. All of this are statistically significant compared to all the other groups in the Corona cohort, and except for diabetes, which was comparable with other groups. And some important data which is derived from this article is the incidence of depression in rheumatoid is about 33%, and cardiovascular disease is 2 to 18%. So which, as we know, would cause premature mortality and sudden death. And osteoporosis is 30%. GI disease 1 to 22%. Malignancies 0 0.3 to 12.5%, infections less than 9%, and lung disease is 1.4 to 8%. Those who want to take it further on the epidemiology of established RA, we know that, after the 2010 ACR-EULAR criteria, obviously the prevalence of rheumatoid arthritis in the community would be much more than what we saw in the previous data. If we don't have that data, now the nuances of seeing about established RA, early RA, you can see if you can look in this paper. Those interested can go into that. Next interesting study I thought was interesting was, this is a study from Scandinavia, published in Occupational and Environmental Medicine 2019. The study looked at from 1993 to 97 farming tasks and the development of rheumatoid arthritis in the agriculture. It's called the Agriculture Health Study. And this is almost 50,000 people who were exposed to these occupations. They followed up from after that. And what the study finds is, if somebody is exposed to chemical fertilizers, the hazard ratio of developing rheumatoid is 1.5 times, or exposure to non-gasoline solvents, the hazard ratio is 1.4. If you are exposed to painting, the hazard ratio is 1.26. Now, so from epidemiology to environmental exposure, and coming to the role of microbiome in the etiology or etiopathogenesis of RA and treatment, this is a review article. This is an important observation made from these are people from Mayo Clinic, published in Advances in Musculoskeletal Diseases in July 2019. The x-axis is DMARD treatment, and the y-axis is disease severity. And the dotted green lines, a normal healthy population where you have these commensal microbes. But if you look at people with rheumatoid, these are two groups of people with rheumatoid. And if you look at the blue line are rheumatoids which respond to treatment, and as time goes by, their microbial flora becomes almost like the commensal microbe. But those who don't respond to treatment, non-responders to treatment for rheumatoid arthritis, they have pathogenic microbes in their microbiome. So clearly indicating that the microbiome is different from a responder to a non-responder, or the importance of microbiome in the pathogenesis, etiopathogenesis of rheumatoid. I just picked up some specific articles. These are with references because of lack of space. I just haven't put the references, but these were all between last 5 years. If you give patients on methotrexate have reduced abundance of Enterobacteriaceae, another study has shown the methotrexate restored the gut microbiota in some patients, in these patients. Meanwhile, also sulfasalazine, on patients on treatment with sulfasalazine, there is a significant increase in the bacillus and decrease in the total aerobic bacteria, E. coli, and bacteroids. And there is a reduction in the number of total non-sporing anaerobes, Enterobacteriaceae, and opalocin negative Clostridia. Similarly, patients on hydroxychloroquine increase the microbial species richness, the diversity of the microbial species, and we give hydroxychloroquine plus doxycycline led to the reduction in the abundance of bacteroiditis and formiculitis. Now, from epidemiology to environmental impact to microbiome, now coming to the genetics. So all of us are aware of the multiple Jiva studies and SNPs involved in RA. I'm not going into detail of that, but I just want to bring to your attention two of the epigenetic mutations which have been explained in the last 3 years. That is microRNA 613 and microRNA 22, which have a protective role in rheumatoid arthritis. MicroRNA 613 and microRNA 22. I'm not going to that study, but I choose this study for the genetics of rheumatoid. This is published in Journal of Genetics, impact factor of 0.9, but I still felt this is important for us. Genetics and expression changes in TNF-alpha as a risk factor for rheumatoid arthritis pathogenesis in Northeastern India. So what they looked at is associative role of TNF-alpha 308GA polymorphism and the differential expression of TNF-alpha in the pathogenesis of RA. And those patients who had RA had a high incidence, and 46.03% of RA patients had this genotype compared to 25% of the controls, which was statistically significant. But this was not associated with severity of the disease. But if you have phenotype variant GA genotype in the Northeastern population, the odds ratio for rheumatoid arthritis was 2.6. Now, coming from genetics to epigenetics, I briefly mentioned about the microRNAs. This is, if you need to know details about the epigenetics in RA, this is a very good article which I found in Seminars in Immunopathology in 2017. The post-translational protein modifications of citylation of arginine by PAD, as well as carbamylation of lysine described and its role in pathogenesis. And they contribute to the breaking immunological tolerance by creating new epitopes of various autologous proteins. Now, coming from genetics and epigenetics to diagnostics, synovitis is, all of us know the increasing role of imaging in rheumatoid. Synovitis in RA detected by grayscale ultrasound predicts the development of erosions over the next 3 years. This is an article this year in July 2020, Oxford Rheumatology by Moller and colleagues. This is the Swiss team. This is a sonar group of musculoskeletal ultrasound. And so this data is from the Swiss registry. So they did ultrasound, both grayscale, power Doppler, and a combination of both, a combination ultrasound to predict whether this, if you get a patient, you do this, whether this will predict joint damage progression in RA. So they devised a score where the maximum, the 54 joints were counted, both wrist and the 16 finger joints, and each joint is scored from 1, 2, and 3. The maximum score is 54. So how the study was done is all patients had sequential hand X-rays, and during the first X-ray, an ultrasound assessment was done. And then after 3 years, that is after 3 years, the X-ray after 3 years was compared with the X-ray at the beginning and the ultrasound findings at the beginning. And so all the patients, it was close to 300 patients, based on the score, they grouped into more than normal, 50th percentile, 75th percentile, or 87.5 percentile for the progression of damage on X-ray. And so I think it's clear. So that Swiss registry, rheumatoid arthritis patients, X-ray and ultrasound at first visit, and subsequent follow-up hand X-rays, and last X-ray at 3 years, and you compare the damage at the third X-ray, at the X-ray at the end of 3 years with the first X-ray, and find out what factor could predict the risk of damage at the end of 3 years. So they look at all our usual things which we would have looked at, including age, sex, smoking, disease duration, ACPA positivity, RF positivity, DAS score at recruitment, CDI, SDI at recruitment, or DMARDs at recruitment. Obviously, once they're recruited in the study, they have aggressive treatment and intensive treatment. And as you can see, I'm not going through the odds ratio, but if you look at the odds ratio, none of them are significant. None of this could predict the damage at the end of 3 years. Now, coming to the next slide, this is the grayscale ultrasound. If you were in the 50th percentile, your odds ratio of developing damage at end of 3 years on hand X-ray was 1.95. If you were on the 75th percentile, it was like the odds ratio was 2.41. And I've given the confidence interval also, so you can see that significance. Similarly, power Doppler. If you have a power Doppler signal, the odds ratio, if a single power Doppler signal, the odds ratio was 1.28. And for the combined score, the odds ratio for 50, 75, and 87.5, 1.94, 2.2, and 1.38, saying that probably as of now, this study says that if you have Doppler signs of synovitis or power Doppler signals or a combined ultrasound score, which is higher, the chances you have a higher odds of getting erosions or damage on X-ray at the end of 3 years. So now, if you need to look at more interesting articles in our ultrasound in RA, this is the one is the Arctic study, which is a randomized controlled strategy trial. which is published in BMJ 2016, and the TASER study in ARD 2016. So these are two interesting articles which anybody interested in reading more on ultrasound in RA can go through. This is just our team in the department in one of our get-togethers. Now coming to the management aspects, all of us target for treating to target, and these are two articles. One is optimization, a treat to target approach in RA, strategies for a 3-month time point. What do we expect at the end of 3 months? What do we expect at the end of 6 months? There's an article in ARD 2016, and the second one is again ARD 2016, the same month article, a 2014 update on the recommendations of International Task Force. These are the recommendations of T2T, which came up in the past within the past 5 years. And to summarize what they have said is, if the target is obtain an improvement of disease activity indices of at least 50% in the first 3 months, and so that the next 3 months you get another 50% probability of reduction, so your possibility of achieving a low disease activity or remission at 6 months. So the therapeutic goal to reach is clinical remission, particularly those with early RA, or low disease activity in those with established RA, where remission sometimes is difficult to achieve. Now, coming from treat to target to IL-6 inhibitors in those with inadequate methotrexate or TNFi response. This is a study. There are multiple, as you all know, there are multiple studies which looks at tocilizumab, sarilumab, and sirukumab in rheumatoid. But I chose this study because this is a Bayesian network meta-analysis of the RCTs. There were 14 RCTs comprising about 10,000 patients, and comparing the efficacy and tolerability of the different IL-6 inhibitors in those who had inadequate response to either methotrexate or inadequate response to TNF inhibitors. And the ranking probability of ACR 50 response based on something called the SUCRA, or the surface under the cumulative ranking curve, or SUCRA, surface under the cumulative ranking curve. So you look at the response, and of the methotrexate, TNFi inadequate responders, tocilizumab plus methotrexate, 8 mg tocilizumab had the best response, followed by single agent tocilizumab, followed by sarilumab, followed by sirukumab. If you had tocilizumab at 4 mg, the response came below that. So I'm not going to further details. And mind you, adalimumab comes much below that. Obviously, it's like a TNFi non-responder, so adalimumab we expect to be lower down there. But that's the data now. And coming to the now from TNFis, coming to targeted synthetic DMARDs or JAK inhibitors, and effectiveness. And again, there are so many studies on tofacitinib in or JAK inhibitors in rheumatoid. And I just took at this study where the effectiveness and safety of in a cohort study, which was published in ART in 2018, where 21,000 patients of RA, of which 0.8% were treated with tofacitinib, and 24.7% were treated with this conventional synthetic DMARDs. Almost 60% were treated with TNFis, and 13.3% were treated with non-TNF biologics, which include rituximab also. And this is the data from that study, which says that if you have, I'm sorry if it's not very clear, there are different criteria, which were 6 different criteria which I looked at, and just looking at, I'm not going to the details of all the criteria, but if you look at the effectiveness of therapy, which probably summarizes all the 6 criteria together, if they are a DMARD, the effectiveness was 11.1% at 1 year. If it's a TNFis plus or minus DMARDs, it's 18.6%. Non-TNF biologicals without DMARDs, it's 19.8%. And if it's tofacitinib without DMARD, it's 15.4%. And this difference between TNFis, non-TNF biologics, and tofacitinib is not statistically significant. And each of them are more significant than just conventional synthetic DMARDs. Just saying that tofacitinib is as good as TNFis or non-biologicals in patients who to achieve effectiveness of therapy. I'm not going to details of the other criteria because of lack of time. And this is the data from, so now actually you would know like it's about 10 years now since we have been using tofacitinib. And this is the data in, again, ART 2019. There are 17,000 patients of tofacitinib exposure. 52% had to discontinue over long term, and of which 24% were due to adverse effects and 4% due to insufficient clinical response. Now coming to tofacitinib to Barry, so the first interesting article on Barry came in 2016, where it's the phase 2 study by Mark Genovese, where in patients, those who were refractory RA patients, followed by the article by the phase 3 study by Peter Taylor in NEJM 2017, where baricitinib was effective than placebo or adalimumab. And then you have the article by Smolin, which showed the 2019 Journal of Rheumatology, where the safety profile of baricitinib was shown. Now, coming from baricitinib to ubadatinib as a monotherapy, again, this article in June in Lancet 2019, and the current journal, the current edition of NEJM. So the Lancet article showed effectiveness of ubadatinib as monotherapy in patients with active RA and non-responders to methotrexate. And the NEJM article says the better response of ubadatinib to abatacept or in a RA. Now, from JAK inhibitors to the newer JAK inhibitor effect of filgotinib versus placebo in clinical response in patients with moderate to severe refractory RA, RA refractory to DMARD therapy. This is again in JAMA July 2019, where 448 patients with 100 mg once daily, 200 mg once daily, and placebo were compared, and there was a significantly higher proportion of response to filgotinib compared to the placebo. Again, coming to our favorite drug, the rituximab, the Orbit trial in rituximab, where patients RA who had not responding to methotrexate, they were divided into two groups, TNFIs and rituximab, and the remission at 6 months was comparable between rituximab and TNFIs of 2.6 and 2.4. So basically saying that rituximab is non-inferior to TNFIs in patients with RA and naive to biological treatment. And now this coming to the REDO study, whether ultra low dose rituximab, like 200 milligram rituximab, is it as good as 500 milligram rituximab or 1000 milligram rituximab? And as we all know, the response to 500 and 1000 mg of rituximab is the same, but this REDO study says that shows the inferiority of low dose rituximab compared to 500 and 1000 milligram of rituximab. Now coming to newer therapies, mesenchymal stem cell for the management of RA. I know I'm just running out of time, but there are just a couple of slides. So mesenchymal stem cells are effective not by rejuvenating the bone or the cartilage, but the mesenchymal stem cell autologous mesenchymal stem cell transplant acts through its immunological effects. It stimulates the Tregs conversion of M1 to M2 macrophages and inhibits the follicular helper T cells, B cells, NK cells, and the dendritic cells. And there is not much of a repair or paracrine effects of the mesenchymal. It's not much of repair effects for the mesenchymal stem cell. So mesenchymal stem cells has a promising role in resistant rheumatoid arthritis. And the source of mesenchymal stem cells could be the umbilical cord, the adipose tissue, or the synovial dendrite, or the marrow and periosteum. This is from Current Opinion Rheumatology 2017 article actually. Now, as we have seen all the data, we were talking about data of 20,000, 25,000, 50,000, 30,000. So where is research in rheumatoid arthritis headed to? If we need to produce significant data, we need to have large healthcare databases for clinical research. This is the article in March 2017, which emphasizes that the electronic medical records, the three major areas where you get data is electronic medical records, health insurance schemes, and patient registries. which has many of the data which I had shown had good input from these sources. So we need to work on that. And again, as time progresses in the information and digital age, there's an article in Current Opinion in Rheumatology in 2018, the use of technology to support clinical care and research in RA. The electronic health records will increase the quality of clinical care, reimbursements, supportive care for the patient, and the data repositories as well. And EMR has the role to transform management and leading on to increased health, well-being, and satisfaction of patients with RA. So just summarizing, I went from the way of looking at the landmark papers to epidemiology, to etiology, from microbiome to environmental pollutants, to diagnostics, ultrasound, management from JAK inhibitors mainly to Rituximab, and where we have to head, where we are headed to. And thank you very much for your patient listening. And these are the different CMC campuses here. This is the main campus. This is the Kannigapuram campus. And thank you very much.
Thank you, Dr. Matthew, for having given a lucid talk, very crystal clear talk. You have talked about the, started the microbiome, and it was fantastic to know that all the drugs, all the DMARDs, conventional DMARDs we use like methotrexate, sulfasalazine, and hydroxychloroquine favorably modify the gut microflora. We used to combine lactobacillus, something like that, thinking that the gut microflora, normal flora would be disturbed by the methotrexate, and it's exciting to know that methotrexate and sulfasalazine actually helps to restore the flora. Second important point you have made out is, so far the pathogenesis of RA has reached its max zenith in the understanding, but not its etiology. But not much progress has been made so far regarding the etiology of RA. But you have pointed out very well. So far, we thought the coronary artery risk is 5 to 8 times increased in RA patients. You said it is 2 to 18%. Now, more than that, around 33% they have suffered from depression, silent depression. Depression kills more people than the disease itself. So, as a modern day rheumatologists, we have to focus on treating depression, and we have to include psychiatrists in the modern day approach of treatment of the therapeutic armamentarium of rheumatoid arthritis. Apart from that, you have talked very well about the other latest drugs, including the JAK kinase inhibitors, and it was very interesting to note that the ultra low dose Rituximab, that's what we commonly use, as low as 200 could be useful, but you definitely said it 500 is effective. Overall, it was a fantastic talk, and it opened our eye that we have to look for early clinical remission in the first 3 months. That is very, very important. So hit it aggressively should be the policy for the treatment of RA, like the pyramid was reversed even 1 decade back. Thank you, Dr. Matthew, for your crystal clear talk. The next session would be by Dr. Latika Gupta. Dr. Latika Gupta has graduated from SGPJ Lucknow, and now she is working as an assistant professor at SGPJ Lucknow. And her area of interest is in myositis, and she has got numerous publications on her credit. Now, the myositis is an area which is so dark in rheumatology because all the systemic autoimmune connected diseases are associated with the myositis. And when it comes to overlap syndromes, whether it's an overlap syndrome or overlap, just overlap, we don't know most of the occasions. So myositis always proves to be enigmatic. And I would like to request Dr. Latika Saran to throw more light on about the recent papers in myositis in the next 30 minutes. Over to Dr. Latika Saran.
Warm good evening to all of you. And thank you, Professor Ghosh and Argo, for having me on board today. And I'm truly honored to be part of this activity and very excited to meet our young scholars. I must say that my job is easier as compared to Professor Matthew, with the limited number of publications in the field. So I believe all of you would be familiar with the concept of inflammatory myositis. Despite its rarity, it is important to understand more about this condition and study the landmark papers in the area, because it is a morbid condition and can also lead to mortality. And this is the area where you can potentially save lives with timely therapy. So together today, we will discover the story of myositis, ranging starting with the times of Bohan and Peter, followed by the various autoantibody discoveries that lasted decades, and then the realization that not everything in myositis is autoimmune, and moving slowly towards precision medicine after weaving the various bits together. So our understanding of myositis has considerably evolved over the decades. In the times of Bohan and Peter, the 5 types of myositis which were described were idiopathic DM and polymyositis, cancer-associated dermatomyositis, juvenile forms of dermatomyositis, and overlap forms of myositis. But with time, there is recognition of inclusion body myositis and the newer entity antisynthetase syndrome, which we will talk about in a bit. So the first descriptions of myositis go back to 1860s, where a unique muscle disease with cutaneous rashes was described. And these were from Germany and Paris, followed by Unverricht's description of a polymyositis, which is acutely progressive. So this was called polymyositis, but this 27-year-old stonemason had muscle pain, weakness, facial swelling, and a lilac-colored discoloration of the eyelids. And this gentleman succumbed to his illness within 6 weeks. And on biopsy, they noted that the lungs were edematous, and so were the muscles. So interesting to note how much we may have to learn from history, because this is a stonemason and the association with silica is well understood now. And in fact, just 2 weeks back, there was a paper which described the association of silica exposure in lupus and systemic sclerosis, and it is also being recognized in myositis. So taking this cue from history, we will go over the history of myositis, and over time, many names have led to a massive conundrum in the publications where myositis has been referred to in various ways. But after the initial descriptions, it was almost 40 years later, 30 years later, that DM was known to associate with cancer. There were around 28 to 30 cases of dermatomyositis, and most of these were men who were over the age of 50. There were a few reports where polymyositis was associated, but these were much fewer in number. And it was only in 1930 that Gottrin described the classic rashes on the knuckles and the papules, along with the lilac-colored discoloration over the eyelids, which was associated with edema, and the various rashes, including V sign and Scholl sign. So the hand rashes were later came to be known as Gottrin's rashes. So juvenile dermatomyositis was described much later. Only in 1940, the first case report came by, and at that time, it was thought to be a severe and fatal form of vasculitis, which was refractory to all forms of therapy. In 1942, it was known that cutaneous manifestations can come before myositis, and this can look like lupus. So clinicians learned how to differentiate the two. And it was only in 1975 that CADM, that is clinically amyopathic dermatomyositis, came to be known and was later called so 4 years later. So Bohan and Peter's classic description of myositis is the first and most important landmark paper in the history of myositis. And it heralded the onset of the second era, wherein the discovery of autoantibodies and better understanding of the disease began. And we'll go over this paper very carefully, as there's much to learn from keen observation and history, as we will see in a bit. So this paper was published in the New England Journal of Medicine in 2 parts. So the first of the parts described the clinical manifestations and the 5 phenotypes, and the second one focused on the laboratory, electromyography, and biopsy features of the disease. So the 5 types of myositis, which were described in this paper, are the idiopathic PM and DM associated with neoplasia, rarely PM, which can also be associated, JDM with vasculitis and overlap forms. And Bohan and Peter described 5 criteria, which I believe all of you would have heard of earlier, but the clarity with which they went over each bit is almost mesmerizing when you read the paper. So in the interest of time, we will not be able to touch upon all bits of the paper, but I suggest you go back and read it. That's the only way you can do justice to this beautiful paper. The Bohan and Peter also went on to describe why steroid responsiveness was not included in the criteria after much contemplation, because not all patients are steroid responsive, particularly JDM and sometimes cancer-associated myositis, and also because some of the other mimics can respond to steroids. So way back in 1975, they knew that steroid responsiveness could be seen in the other myositis mimics, things which were confirmed later. And so many years down the line, we have another classification criteria, but the researchers are still struggling to get foothold on a good criteria, which would be better in any way than Bohan and Peters. So in this landmark paper, they describe the problem of diagnosis, which is often faced in the clinic. Childhood dystrophies, which typically will have calf enlargement or a slower course or a family history, can be suggestive. But calf enlargement can also be seen in childhood DM. This is what Bohan and Peter note and provide appropriate citations and say that DM can also co-occur in 2 family members. So this cannot be an exclusion criteria for the diagnosis. Motor neuron disease is another condition which is often ignored in the clinic, and these patients can have a similar EMG profile, and they can have mild CPK elevation and a similar pattern of weakness. So it is very important to distinguish, and muscle biopsy can be useful in this subgroup. Then there are other forms of muscle disease like endocrinopathies, myasthenia, drug-induced, and interesting but unusual additions like influenza and rubella infections, giant cell myositis, atheromatous microemboli, etc. So they detail all the various kinds of differentials which may be considered while making a diagnosis. And it's absolutely marveling to see how much information they gathered way back in 1975 with an extensive research and a review of literature. And again, they iterate that CPK is the most sensitive marker, although not infallible, because sometimes it can be elevated. It can be normal despite active myositis. The decrease is typically seen earlier than clinical improvement, and various markers may not be useful in the management of myositis. So they're very clear about what is useful and what is not. That is the beauty of this paper. And in the electromyogram, the authors note that paravertebral muscles can sometimes be involved. And in fact, 2 cases seen by Peter had involvement of only the paravertebral muscles on an EMG. Further on, they describe the classic biopsy characteristic, the perivascular atrophy, which is almost characteristic, and the other features which are more commonly seen, but notably, they also describe what is now known as the necrotizing myositis or muscle necrosis with minimal to no inflammation. So again, a result of keen observation, they describe a condition which came to be known almost 30 years down the line. And researchers are still struggling to understand more about that condition. And also they conducted biopsies in Peter's cohort, and some patients were biopsied 3 times, but only one of the sites exhibited inflammation, suggesting that the nature is extremely patchy. And then they also conducted electron microscopy in this wonderful paper and described inclusions at times, which can be seen with influenza, the MX particles which are suggestive of interferon activation, which are seen in post-influenza illness, and these were also described in another paper in Science. It is interesting to know that IgM, IgG, and C3 deposits were also recorded by Bohan and Peter and reviewed in the literature that they describe. And these findings are now becoming very important, as we'll see in the subsequent slides. They also discuss the immunology behind IIM, the SIRA reactions. So sera from patients when injected could elicit a cutaneous response in the non-diseased, and the isolated lymphocytes were cytotoxic to the muscle of various animals and also humans. They also had increased lymphotoxin production, which decreased when incubated with steroids. They also discussed the concepts of treatment in this landmark paper. So steroids are the mainstay of therapy, and high doses are typically used, although the doses described are largely 1 milligram per kg, which may explain the poor response in JDM, where typically higher doses are used these days. And they go on to describe the definition of response. It was really exciting to see that way back they described that response may be assessed at 4 weeks, where a decline in muscle enzymes is typical, but not of the weakness, because weakness may take longer to improve. And this is precisely what we follow even 30, 40 years down the line. And they also describe steroid resistance, a concept which we still struggle to label, and used an arbitrary definition cutoff of 3 months. Further, they said that to discontinue steroids, there was insufficient data, and there continues to be insufficient data even now, so many years down the line. Regarding steroid-sparing agents, some of you may be excited to know that the first suggestions were made by none other than Professor Malviya in this landmark publication in The Lancet in 1968, where he described 4 patients with DM who were treated with IV methotrexate, and this was later confirmed in another series of 22 patients, where 3/4 responded without major hepatotoxicity. And this paper was cited in the Bohan and Peters landmark paper. Further, Bohan and Peter described what are the facts, fancy, and fiction related to myositis. And a conventional knowledge revolves around evidence, and facts were based on that, while the misgivings about the knowledge were also highlighted, suggesting which is the direction for future research. Well, that was the era of Bohan and Peter. This led us on to another exciting venture where in the 1980s, there was the discovery of various autoantibodies, beginning with the anti-MI2, followed by the anti-synthetases, the most common ones first, that is anti-Jo1, PL7, and PL12. This was mainly by the immunoprecipitation assay, which could detect very tiny amounts of antibodies due to its sensitive nature. A lot of this work was done by Richlin and Ira Targov in the United States. As you can see, the discovery timeline of autoantibodies has continued on since then, and we continue to describe newer autoantibodies in the current years. However, the newer autoantibodies, if you were to see this timeline, precisely TIF1 gamma and anti-MDF5, they constitute a large proportion of children with JDM. So the understanding of juvenile myositis has trailed behind adult myositis in that sense, that most of the autoantibodies which involve these, which are present in these children were discovered much later. Further, the role of myositis antibodies was explored, and it was understood that they probably may be a result or may also contribute to muscle damage, which contributes to regeneration and leaky muscles. And this may accentuate HLA1 overexpression, which is very crucial in triggering downstream activation of the immune pathways, which lead on to myositis inflammation. While immune mechanisms were all that were focused on for a long time in myositis, especially with the discovery of the various autoantibodies, it was only in the year 2000 that the first successful animal model of inflammatory myositis paved the way for a better understanding of the pathogenic mechanisms. So not many of you may know, but Professor Nagaraju is an alumnus of SGPGI, and so a byproduct of Indian rheumatology in some ways, now placed in the United States, and has done some seminal work in the area where in this animal model where they upregulated MHC class 1, they used H plus T plus mice, that is tetracycline responsive mice, So the tetracycline gene was tagged to the CPK, to the muscle-specific kinase. And when tetracycline was administered, the MHC class 1 was upregulated. So they needed to do that because otherwise the condition of MHC class 1 upregulation was not consistent with survival. So once this MHC was upregulated in these mice, they noted that at 1.5 months, there was hardly any immune infiltrate. And this went on to increase gradually at 3.5, and at 5.5 months, there were florid inflammatory infiltrates in the muscles. But weakness was recorded as early as 1.5 months, which was surprising. And this suggested that possibly there are other mechanisms apart from autoimmune damage, which is ongoing in these inflamed muscles. And later, almost 12 years down the line, the same author group found that this was due to deranged cellular bioenergetics. So the enzyme AMPD was dysfunctional in this group of mice, these mice. Further, in the discovery timeline of various autoantibodies, one that deserves special mention is that of the CADM140, or the antibody to a 140 kilodalton polypeptide. So in the immunoprecipitation assay, the Japanese described almost 8 patients among 42 of those who had DM in their very large cohort of nearly 300 sera. So of the DM, only 8 of these had these bands. All of them had the same band in the same region, which later was a 140 kilodalton protein, which later they were able to characterize as anti-MDF5. So on ANA, all of these patients had a similar pattern on immunofluorescence, which was granular or reticular. And why this was important, because these patients had a very high risk of rapidly progressive interstitial lung disease, as you can see, 50% versus 6% for the control group. Another point which deserves special mention is the survival in this group was extremely low because of the rapidly progressive interstitial lung disease. And it was important to understand that these patients may never present to the rheumatologist, rather may come up with critical care or pulmonology. The curiosity around this condition further increased when the first reports were published from the British and the ZEC cohort, where these patients were found to have very mild disease, totally contrary to what was found to the Japanese population. So in Japan, the first reports were mostly surrounding the Mizo River, and this led the researchers to postulate that probably some environmental factors were at play. But in the British, it led to a mild disease, suggesting that important environmental and genetic influence was important to lead to this condition. However, in the Americans, a dual phenotype was later noted, and the same has been recorded in the Indian population. The prevalence is intermediate between the Japanese and the British. So while these are the autoantibodies associated with ILD, we talked about MDF5, but then there is the anti-synthetase syndrome cluster of autoantibodies, and there's increasingly better understanding of this condition as well. And as we go deeper into the autoantibodies, you'll realize that these are the Watson to Dr. Holmes, and how important it is to measure these in the clinic. For example, this paper in Medicine 2015 described the clinical spectrum over time of patients who were anti-Jovan positive. And most of these were incomplete forms at presentation. So as you can see here, a lot of these patients, only 25% of them had the complete anti-synthetase syndrome at presentation, while the number gradually increased with time. So this is the cohort that was tested, and only 1/4 had complete ASSD, and of the incomplete forms, arthritis was the most common. So a lot of these could be misdiagnosed as rheumatoid when not tested for myositis antibodies. And at 12 months follow-up, nearly 1/3 progressed to complete ASSD. So most of these develop new manifestations on follow-up, which require management. ILD is the most prevalent ex novo manifestation. Now, the progression is rather slow, and critics may like to say that only 1/3 are progressing to complete forms. So why is it important to understand this? It is important because these are also antisynthetase syndrome, and these can present with largely pulmonary disease. Fewer of them have muscle disease. As you can see here, 30% in the Jovan ASST, but the non-Jovan forms have muscle only in 14%. And the reason this becomes more important is that these patients can have poorer survival. So it is diagnosed late because they do not present to the rheumatologist, or even if they present to the pulmonologist, testing may not always be available, or awareness may be low, resulting in median delay in diagnosis of 1 versus 0.4 years. So while Jovan was more likely to be diagnosed earlier, as you can see for the first 15 years, there's a wide gap between Jovan and non-Jovan, with a lower survival in the non-Jovan disease. And the cause of death, notably, is pulmonary fibrosis, suggesting that this is something which may be amenable to therapy provided we can diagnose them early, as a lot of them have NSIP, which is treatable. And the median time to death was, again, 6 years versus 3 years. Another important observation is a lot of these patients may be autoantibody negative, and anti-cytoplasmic antibody may be very useful to screen these individuals. So not all centers are reporting anti-cytoplasmic antibodies in ANA, but it is very important when you're suspecting myositis or are investigating a patient with interstitial lung disease or isolated arthritis. So ASSD cohort in Pittsburgh, 72% had anti-cytoplasmic antibodies. Of these, 82% were negative for anti-nuclear antibodies, while for the other controls, merely 11% were ANA negative. So always look out for anti-cytoplasmic and ask your laboratory if they have specifically looked for those. Now, another condition which is challenging and at times frustrating to treat in myositis is calcinosis, less so in adults and more in juvenile forms of myositis. And this landmark paper, which came across as a breakthrough in science, especially in the field of myositis this year, it was also a plenary session at the ACR and called for a lot of discussion, where the new mechanisms or the missing link in the pathogenesis of calcinosis was understood. So here the authors found that neutrophils engulf calcium crystals, more so in all patients of JDM who had calcinosis. So neutrophils try to engulf calcium crystals, resulting in a frustrated phagocytosis. And this culminates in netosis, that is formation of neutrophil extracellular traps. And this is mediated by reactive oxygen species and peroxidase. Notably, it's not mediated by PADI, as is seen in rheumatoid, but this suggests a possible pathway which may be amenable to therapy. And once this pathway is triggered, there are other players like platelets and complement activation together with dyslipidemia, which may be crucial for accentuating the tissue injury. So the importance of this paper lies in the fact that it opens new doors for therapies in a condition which is otherwise deemed to be refractory to all forms of treatment. So we have a whole range of new drugs which can now be tried in this condition, and we definitely have hope for a better future for these patients. Now, this session on landmark papers would be incomplete without a fleeting mention to the RIM trial, which is the first big trial in myositis. Apart from a large cohort of adults and children, it also was the first one to introduce the core set. The core set is a collection of 6 outcome measures in myositis. And while I'll leave you to read this by yourself, this trial was remarkable in more ways than one, in that it was a failure due to the faulty design. So here they compared early and late rituximab, and because rituximab may take 8 to 12 weeks to act, both the arms could not meet the primary point, which was the difference between early and late rituximab. But this trial anyhow demonstrated 80% response rate in patients who were refractory to other therapies, at least 2 other drugs. So this established a place for rituximab in the management of myositis. For children, the most important and probably one of the only trials was that which compared prednisolone with prednisolone plus cyclosporin and prednisolone plus methotrexate. And there was a clear better survival with prednisolone plus methotrexate. Cyclosporin also did well, but led to more events of adverse effects such as hypertension in children, due to which it is not advocated as a first line. But following this trial, steroids plus methotrexate are the first line of therapy in children, more so because growth and other parameters can be affected due to long-term steroid use. With changing times, definitely there's been an era of earlier treatment, era of treatment of steroids with other steroid-sparing agents. So cyclosporin has shown some benefit in ILD, and this field is rapidly evolving, and various trials are ongoing, and we hope to have more in this area in the future. Lastly, with anti-MDF5 measurement and treatment, we're moving more towards precision medicine in some ways, because this subset has shown better survival with very aggressive therapy at the outset. So this paper from Japan, which was published recently, showed that high-dose steroids with cyclosporin and IV cyclophosphamide, when given together, has much better survival in this group of patients. So while this session is too short for all to be covered, I'll suggest the supplement in Nature Reviews, which was published in May 2018 for further reading for all of you, and happy to take questions.
Thank you. It was a presentation it was more of a historical perspective, comparing how the treatment, epidemiology, various clinical science evoluted from 60s to late 2020. Of course, it was nice, and probably like a frustrated phagocyte, the treatment of myositis still proves to be elusive and frustrating too. So probably let us hope for more better developments in the future, and all the scholars are requested to verify the internet to go for further exploration of any new papers on this aspect.
CNS involvement in IIMs, especially demyelinations.
So although these are described, they are the exception rather than the rule, and more so in the overlap forms as we would expect, like lupus and Sjogren's. But classically in DM, to the best of my knowledge, there are not too many reports. I'm sure there would be few, as we usually have for everything, but I have not conducted a systematic search on that. Any data regarding the role of cyclophosphamide in IM in cases with ILD and RP-ILD? And yes, there is data, but it is limited to small case series, which have shown some benefit, but due to the absence of a control arm or a structured study design, it is difficult to quantify the exact benefit. But with rapidly progressive ILD, better response is seen with combination therapy, the trial which we talked about, where they administered cyclosporin with cyclophosphamide and steroids. But there was a very high rate of CMV activation in that group, so it merits exploration and probably testing for CMV and prophylactic cover for infections in the treatment arm. So another attendee says that the indication for use for rituximab in IIM. So while rituximab is still not the first line, as we saw in RIM trial, it was beneficial in those who were refractory to at least 2 drugs. And that continues to be the same, although it may have climbed up by at least 1, and it's now second-line therapy for most. While for anti-synthetase syndrome, there may be some benefit there. Even in the subgroup analysis of RIM trial, patients who were Jo1 positive and MI2 positive had better response to rituximab. So that may be the group where it may have a larger role in management of the condition.
Yeah, we can proceed on to the next session. Good evening, Dr. Shanai. You are welcome. And you appear to be more tranquilized and at the end of a hectic schedule. I think we are very eager to listen to you after a long time. It's very unusual to meet you over the online webinar because I never took part in any webinars last 6 months or so. We were so busy in treating COVID patients. Now, everyone knows about he is a national treasure. Badmar Shana is a national treasure, and he is a very dynamic person, not to exaggerate. And secondly, Dr. Shena is so diplomatic, scholastic, and he's always keen to learn more. Seek, learn, serve is his purpose. That's why he has established CAT Center at Kerala. Seek, learn, serve. So it's your attitude towards rheumatology is quite amazing, Dr. Badrunam Shanai.
Thank you, sir.
And
thank you for blessing, sir.
He needs no further introduction. And I request Dr. Shanai to deliver his talk on reason papers in scleroderma, systemic sclerosis.
Thank you. At the outset, let me thank Alakendu sir and Sapan sir and Argya for this opportunity. So I thought I will restrict better to, I am a pure historian. I believe in, I thought I will just try to tell you what is the evidence, how the evidence in scleroderma has evolved. And what are the important trials as a fellows you should always remember, and how the treatment has evolved and what is the standard of care currently. So when I was doing DM, there were a lot of skepticism. Should we treat scleroderma? And I am sure a lot of, I had a debate with Sapan sir when we were in Kolkata. Alakendu sir proposed that topic, telling, should we treat scleroderma? And we had a very, very fierce debate. So the 5-year mortality of scleroderma, which was is in American Journal of Medicine 2005, showed that 5-year mortality of scleroderma is much higher than many of the cancers. They have studied 3,000 patients, 20,000 patient years. At the end of 5 years, 40% of the patient die. The problem is that when a scleroderma patient walks into our room, we never realize that they are having this bad outcome. If you look at the standardized mortality rate, SMR of scleroderma is 5 to 7 times of the population. It is highest among CTDs. Maybe vasculitis comes there, but it's highest among all the CTDs. Even lupus nephritis has 2.2. As rheumatologists, we will be very keenly treating lupus nephritis, feeling that they are going to die. But the problem is that scleroderma is a slow killer, so we think that's a benign disease and we can observe them. As a students of rheumatology, we need to understand this fact very clearly. And what is the 5-year mortality prediction? This landmark paper appeared in Arthritis Rheumatism way back 20 years back. They looked at only 3 things: positive urinary protein, ESR of more than 25, and DLCO less than 70. Although most of our patients will not have proteinuria, they will have elevated ESR and DLCO will be less than 70. So if you have 2 risk factors, their mortality, 5 to 10 year mortality is very high. Things have changed over time. I'm not telling that things have changed, but it's not dramatic change. And there is no doubt about morbidity. All of us will agree that scleroderma is a very morbid disease. And FVC predicts mortality. There is no doubt about it. This is again Steen's landmark paper in Arthritis Rheumatism, which was published way back in 1994, which showed that if the FVC is less than 50, the patient, the 10-year survival is as low as 50% or less. But if you have a normal lung function, survival is much better. So the single most predictor after the people have started treating scleroderma renal crisis is interstitial cardiopulmonary causes. So majority of my talk, I will focus on cardiopulmonary causes. This was the landmark paper which appeared in way back in 2006 in New England Journal, scleroderma lung study by Tashkin. They treated patients of scleroderma who had interstitial lung disease as defined by ground glass opacity, and half of them were given oral cyclophosphamide and half of them were given placebo. And 79 were treated with cyclophosphamide and 79 were treated with placebo. And as you can see here, this shows what is the lung function. This is dotted line shows cyclophosphamide, and the straight line, the completed line shows placebo. As you can see here, placebo, the post-vital capacity decreased over time, while in cyclophosphamide, there was a stabilization, and at the end of 1 year, there was a difference of 2.53%. 2.53, whether it's clinically meaningful, that was the biggest criticism. Major criticism is that change in FVC is not clinically meaningful. But When we look at dyspnea, as we can see here, the transitional dyspnea index. What is transitional dyspnea index? It indicates the change from baseline. For example, everybody's dyspnea at baseline is taken as 0. If it improves, it becomes positive. If it decreases, it becomes minus. And MCID, minimally clinically important difference, is 1. So if and cycloarm improved by 1.45, while placebo worsened by minus 1.5. So difference is 3 times that of the MCID, or between placebo arm and the cyclophosphamide arm, there was a difference of 3. So this was very significant. And you look at the quality of life, cyclophosphamide, almost all the p-values are significant. SF36, physical score, mental score, HAQ-DI, everything, etc. All the scores were improved. Then what happens? After the major problem with scleroderma trials were there, they were not funded hugely by majority of the majority of the funding agencies, and pharma was not involved because of fibrotic disease. So they had to end the study around 12 months, and they observed the patient. That's all. So study duration was 12 months, and after that, the patients were not given any maintenance, and they were observed. So after 12 months, as you can see, the FVC of the cyclophosphamide arm kept on improving, and at the end of 18 months, there was a difference of 4.5. If you remember here, at the end of 1 year, it was only 2.5. At the end of 18 months, it was 4.5%. So it kept on improving. Why did it happen? Because if you have treated the inflammation during the first year, it prevents the fibrosis in the subsequent years. You are not treating the fibrosis, you are treating the inflammation, which will lead on to fibrosis. And control of inflammation during the first year impedes the progression of fibrosis till 1.5 years. So that was the message. Then, because there was no maintenance, what happened at the end of 2 years, both the arms were similar. What did it tell us? It tells us that we need maintenance. So if we did not have maintenance after 1.5 years, the curve starts dipping. And it is colossal blunder to think that scleroderma, being an autoimmune disease, can be cured with 6 months of cyclophosphamide. What about adverse events? We say cyclophosphamide is very toxic. How can you give cyclophosphamide a longer time? In this study, for 1 year of cyclophosphamide, the serious adverse events were almost similar. And all mortality was disease-related, and none of them were treatment-related. The message is, cyclophosphamide is not a bad drug in the treatment of scleroderma interstitial lung disease. This was another study, fast study. I don't want to go into details of this. Just want to tell you how a study can mislead you. Out of the 23 patients allocated to active treatment arm, only 15 completed. So there was a huge dropouts. And with such a kind of dropouts, better not to talk about the study. Then came, after 7 to 10 years, there was another study which was SLS2 trial done by Dinesh Khanna and his colleagues. SLS2 trial, which was published in Lancet Respiratory Medicine in the year 2016. They took early scleroderma patients with an FVC of 45 to 80% and having an HRCT showing ground glass opacity. They randomized into 2 arms. To one group, they gave oral cyclophosphamide for 1 year, and the second group, they gave mycophenolate for 2 years. Why did they do this? They wanted to prove that 2 years of mycophenolate is superior to 1 year of cyclophosphamide. And there were 142 patients who were recruited, and as you can see here, they had a pretty good FVC. FVC was around 66% in the 66 to 67% in the both arms, and they had a relatively early disease. As you can see here, this is red one is cyclophosphamide and the blue one is mycophenolate. At the end of 2 years, 1 year of cyclophosphamide and 2 years of mycophenolate were having similar outcome. Although both the FVCs improved, they couldn't prove that 2 years of mycophenolate is superior to 1 year of cyclophosphamide. To me, it says one thing: in scleroderma ILD, there is improvement in FVC both in cyclophosphamide and mycophenolate. In fibrotic disease, people always used to believe that fibrosis is irreversible. You cannot improve lung function. But this study proved that there can be an improvement, not stabilization. And their adverse event profile showed that mycophenolate mofetil was better tolerated than cyclophosphamide. This is our own study, which we had published in 2016. This was not a randomized control trial. This is a retrospective analysis of our data. And as you can see here, when compared to SLS2, our disease duration was higher. What we used to do, we used to treat the scleroderma ILD like what we have been treating for ages, IV cyclophosphamide versus mycophenolate mofetil. Some of them were given IV cyclophosphamide because of the cost, and some of them were given mycophenolate 2 to 3 grams. And baseline FVC was around 48 to 50%. So indicating they had a much severe disease, SLS2, SLS1, they all had 65, 67% of FVC. So Indian patients get picked up late, and their FVC, baseline FVC itself is much lower than the Western cohort. We also could show the similar data, both cyclophosphamide and mycophenolate mofetil. Both, you can see the blue line is cyclophosphamide. The FVC improved from 48 to 53, and in the MMF arm, the FVC improved from 53 to 55. So both of them were equally efficacious in improving the post-vital capacity. I just want you to show something. See the similarity of results. This is our retrospective data. This is SLS2, almost similar. In both the arms, there has been around 5 to 7% improvement in FVC over 6 months to 1 year. So the message what I'm trying to tell you, the fellows who are the future of Indian rheumatology, is that retrospective data is useful if collected and analyzed well. So it's extremely important. Saban Bose always tells us, whenever you start practice, keep your data. You can always retrospectively go and analyze it and come to meaningful conclusions. So when we looked at the SLS2 data, another important thing which has happened to us is that 2 years of mycophenolate mofetil was not superior to 1 year of cyclophosphamide. So should we immunosuppress for longer time? So again, we went back to our own data. I'm just telling you, this is not a landmark paper, just for how the treatment has evolved and how you should treat them. I'm just trying to convey that. So induction therapy, 57 patients, 46 were under follow-up and 11 defaulted. And so India, that happens. People keep on defaulting. So we just try to trace out our patients' data, what happened to those patients who defaulted. And as you can see here, those patients who defaulted, their mortality was 44%, and those who were on maintenance, the mortality was only 10%. So there was a huge difference in mortality. The message is that if you don't keep the patients on maintenance, the patients die. Again, telling the same thing, that scleroderma is a deadly disease. And those who are on maintenance, 46 patients, we had only 5 deaths, so 10% mortality. You can see the survival chart here, again showing the same difference. So coming back again to the landmark papers. So this is the chart from the SLS2. What happens to patients who are, once you treat with a mycophenolate or cyclophosphamide, around 60 to 70% of them respond. You can see 70% respond to mycophenolate, 65% respond to cyclophosphamide, but there's a significant percent, around 1/3 of them don't respond to this therapy. When you say they don't respond, at 6 months or 1 year, they have fall in the lung function. FVC decreases by more than 5 to 10%, and there is a consistent decrease. So what do you do with them? Either the first option, what we do is we switch. There is no evidence for that. Those who are on mycophenolate, you give cyclophosphamide. Those who are on cyclophosphamide, you give mycophenolate. And second option is rituximab. And third option is hematopoietic stem cell transplantation. So let us come to rituximab. Again, this is another proud moment for us. This is from Alakan sir group and Parashar sir's group. And wonderful study published in Rheumatology, Oxford. This is the only randomized controlled trial of rituximab versus cyclophosphamide in scleroderma lung disease. And they included patients who were pretty early, 2 years or around 1.5, 2 years duration. This is the post-vital capacity of 60 to 59%. So quite severe disease. And majority of them had more than 20% of lung involvement. Despite being an early disease, their FVC and CT involvement showed that they had a severe disease. And look at the rituximab, what rituximab did. Rituximab improved the FVC from 61 to 67%, while cyclophosphamide, there was slight drop in the post-vital capacity. So what does it say? Rituximab improves FVC, but this study showed that cyclophosphamide just stabilizes it, or there's slight deterioration. And look at all the p-values. All the p-values at the 6 months were better with rituximab when compared to cyclophosphamide, be it post-vital capacity, be it modified Roten score, be it 6 minute walk distance. All of them were better with rituximab over cyclophosphamide. This is a study done in India, so very relevant to our setting. Then came this SCORE trial, which was one of the landmark trials, which got published in New England Journal from USA. They have done myeloablative autologous stem cell transplantation in patients with severe scleroderma. What did they choose? They chose scleroderma patients who were pretty early, less than 5 years, with interstitial lung disease. Interstitial lung disease means HRCT involvement more than 20% and FEC less than 70%, but more than 45%. Why did they choose that? Because they didn't want to take end-stage lung disease. So, and they took almost like Dr. Parashar's group, Rituximab paper, they have taken patients who are 2 years of scleroderma, average mean duration, disease duration was 2 years. And one thing I wanted to show you here is that the patients who were randomized, so 30 to 40% of them had already received cyclophosphamide. 1/3 of them had already received cyclophosphamide. And they had a very good FVC, 75%. So very early disease, relatively well-preserved lung function. And they were given, one arm was given transplantation, other arm was given cyclophosphamide. And as you can see here, at the end of 6 years, being alive is much, much higher. Survival is much, much better with transplantation when compared to cyclophosphamide. And event-free survival means not having any organ failure and not dying. So both that also was much better with transplantation when compared to cyclophosphamide. I just want you to note something. In the cyclophosphamide arm, there was no maintenance. As I told you in the SLS1, if you don't give, after first year, if you don't give maintenance, another 1 year, the effect of cyclophosphamide will last, and then cyclophosphamide arm will do worse. But in the transplantation, because it has a long-lasting immunogenic effect, they will survive better. And lung function was better in FEC. And so there has been other 2 trials, ASTIS trial and ASSIST trial, which were again done systematically, which again proved the same thing. These were published earlier. And they also showed that bone marrow transplantation is an effective option in the treatment of scleroderma and scleroderma lung disease. But the problem is that there has been a treatment-related mortality. Once you do a bone marrow transplantation, 5 to 10% of them develop transplant-related mortality, which has to be prevented. And so, is it an end of immunosuppression in scleroderma? I with Dr. Amita Madam, we wrote a letter to a New England journal telling that this is not the end of immunosuppression, because once you look at this data, it feels that every scleroderma patient needs to be bone marrow transplantation because cyclophosphamide is definitely inferior. And it has, and bone marrow transplantation has a survival advantage. But first and foremost point is, there is no maintenance given in the cyclophosphamide arm. So if you don't give maintenance, the patient with cyclophosphamide, they will deteriorate, and difference appear at 2 years. So definitely we need better data, comparison of cyclophosphamide with maintenance versus bone marrow transplantation. So Census trial was another landmark trial, which was published New England Journal again last year. They took scleroderma patients who had interstitial lung disease and treated them with either placebo or nintedanib. Nintedanib is an antifibrotic, and if the patient was treated with 150 milligrams twice a day, and if the patient is not tolerating that, the dose was decreased to 100 milligrams twice a day. And as you can see here, the rate of decline of FVC. This was one of the first trials which proved that antifibrotics have a role in the management of scleroderma lung disease. In the nintedanib arm, the loss of lung volume was 52%, while in the placebo arm, there was 93%, or there was around 40 ml per year preservation of lung function. But I would like you to look at this data slightly differently, because this trial allowed background immunosuppression. All of us know that scleroderma is not an autoimmune, just autoimmune disease. It's an autoimmune disease with a fibrotic component. And treatment of this has to be combined with an immunosuppressant along with antifibrotic. So let us look at that this way. Those patients who were on mycophenolate with nintedanib, they had a loss of lung volume of around -40. But those patients who were neither on mycophenolate nor on nintedanib, they had a difference of around 120 ml per year. 110 ml per year. So, in other words, the difference between these two arms was around 75-80 ml, or 5% of lung volume, which is quite significant. So, choice of therapy is nothing but, in the years to come, is going to be immunosuppressants with or without nintedanib. So, nintedanib has a definite role to play in the management of scleroderma, and we need more data, but it has a definite role to play. So, but the major issue with nintedanib is we have been using nintedanib because the cost has come down remarkably over the last couple of months. Diarrhea is a major side effect, nausea is a side effect, and other issue is vomiting. So, how do you treat scleroderma lung disease? Scleroderma lung disease or scleroderma interstitial lung disease, I think what we have to do is regular pulmonary function has to be done, and they have to treat them to target and may stabilize the lung function. The first choice is mycophenolate bar rituximab. And if they stabilize, you move on to maintenance. If they progress, add nintedanib. That's another option. Or change to, if somebody is receiving mycophenolate, change to cyclophosphamide. And hematopoietic stem cell transplantation is an option. But Indian centers, we need to be very carefully done because bone marrow transplantation can lead on to mortality by itself. Then came interleukin 6 blockade. This is a fascinating trial, again from Dinesh Khanna and Chris Denton's group. Early diffuse scleroderma, they treated either with tocilizumab versus placebo. As you can see here, those patients on placebo, most of them, and half of 43 of them received tocilizumab subcutaneous. And at the end of 48 weeks, almost 1 year, there was no significant change in Rodnan score. Although tocilizumab arm was slightly better, but it was not statistically significant. And what they do after that? After that, those patients who completed 48 weeks, they were both the placebo arm and the tocilizumab arm were continued on open labelly into tocilizumab, and it was continued for another 1 year. At the end of 1 year, at the end of 2 years, what happened? This is the blinded arm. After that, this is open label. And once they open labelly, the placebo arm was given tocilizumab. As you can see, the skin score came down, and at the end of 2 years, both arms were similar. This doesn't say that tocilizumab is effective in the management of scleroderma, especially in terms of skin. But it gives some proof that maybe because in the placebo arm also there was a dip in skin score after 1 year, it may give an indirect evidence and it says that we need better studies. That's all. But definitely, the most important point with tocilizumab is that it stabilizes FCC. As you can see here, both in the placebo arm and tocilizumab arm, there was tocilizumab arm stabilized the lung function. There was no loss of lung volume when you treat the patient with tocilizumab. Same was shown by Focus trial. Focus trial, half of them were given tocilizumab and the other half was given placebo, and they were followed up. And there was no definite change in skin scoring. But as you can see here, tocilizumab definitely, the red line, there was a stabilization of lung function, while the placebo arm, there was loss of lung function. How much was it? There was a change of around 167. Again, I'm telling you, it was around 5 to 10% of the FCC, which is really significant. So that's much about interleukin 6 blockade. Now coming to CTD-PH. CTD-PH, there are most of the CTD-PH, the studies have been done in a large cohort of patients who were on PH, and subgroup analysis is done. That's how it happens. The pharma companies don't study for CTD-PH alone. They study for pulmonary artery hypertension, then do a subgroup analysis. And riociguat was the drug, which is a guanylyl cyclase stimulator. And there was 2 studies which were done, patent 1 and patent 2. As you can see here, and there was subgroup analysis which was done, and it was found to be beneficial. Like one slide is missing. And this is the randomized control trial, which is called Ambition trial. Ambition trial is a combination of ambrisentan and tadalafil, and when they compared ambrisentan plus tadalafil versus pooled monotherapy. Pooled monotherapy means either ambrisentan or tadalafil alone. You can see there was a clear survival benefit, both in CTD-PH and scleroderma-PH. So what is the point I want to convey is, if a patient has scleroderma, has a pulmonary artery hypertension, even if it's early, treat them with combination therapy because it is life-saving. If you treat them with monotherapy, their 5-year survival is just around 50%, while in combination therapy is 80%. Still, I keep seeing a lot of people treating the scleroderma-PH with a monotherapy of tadalafil or sildenafil. Always treat them with tadalafil and ambrisentan or tadalafil with macitentan. So just I want to come to my own story. Just not to tell that I have done a landmark paper. It's not a landmark paper at all. This is just to say to our fellows that we can do really meaningful research. This is how when I am from Kerala, which never has winters. I went to Lucknow. The first thing I noticed was that this was the month of September, October. The winter was setting in. There were a lot of people who were presenting with this in the winter climate, Raynaud's. I have not seen Raynaud's in Kerala because it is very less common. And when I did my MD in IPGMER, that also is a tropical climate. There is a temperature around 25, 30. So Raynaud's was not that common. And so we decided that is the time when phosphodiesterase inhibitors were in the market. We have been studying for pulmonary artery hypertension. We treated half of them with tadalafil and some of them with placebo, and it's a crossover design. And after the those patients who received placebo were given tadalafil. And then 24 patients were treated. Only 24 patients were treated, and most of them had very severe Raynaud's. That is, per day they used to have almost an hour of Raynaud's, and they were already on combination of calcium channel blockers and AC inhibitors. This was what was recommended at that time: calcium channel blockers or losartan or Nlap. And with Vikas sir, we did this study. When I proposed this study, Vikas sir was the one who encouraged me to do this study, and there was a lot of hurdles because doing a randomized control trial, blinded trial at that time was not easy. So as you can see here, tadalafil arm decreased the mean frequency of episodes from 3.4 to 2.2, average daily duration of Raynaud's, and RCS also, indicating that tadalafil was very effective in treating Raynaud's. The most important thing was that healing of ulcers. In those patients with tadalafil, the ulcers decreased from 24 to 0. While in the placebo arm, only 3 ulcers healed, while in the tadalafil arm, all of them healed. And also, tadalafil prevented the onset of new ulcers. Those who were on tadalafil, they had only 1 ulcer appearing, while in the placebo arm, there was 13 ulcers. And I was very fortunate, and I think fortunate to get invited to this plenary session. What I'm trying to tell you, the fellows, is that, see, as youngsters, always have bright ideas, and they give fresh ideas. Once you practice for a long time, you get stereotyped, and the ideas has to come from younger generation. Not Alakendu sir, Sapan sir, or me. None of us can give fresh ideas or ideas which can be totally thought-provoking has to come from younger generation. That is why IRA is conducting this kind of fellows retreat, and all of you are the future of Indian rheumatology and has to come up with bright ideas. So if a guy from a normal town can do this, all of you are much brighter and can definitely do a better job. We published this paper in Rheumatology Oxford at that time. There were a lot of criticism. I cannot tell you because this was from India. Somebody, I think Dr. Sapan was there. Somebody came and asked me during plenary session that how is it a black market drug? That's how people used to look at Indian rheumatology or Indian scleroderma researchers. Couple of journals we sent, they told there's no research happening in India. There's no cohort in India. How can you do a study? From that, Indian rheumatology definitely has grown thanks to our leaders promoting research, and a lot of researchers across India are publishing now. So after that, the meta-analysis came. Now, then EULA recommendation has told very clearly that phosphodiesterase inhibitors are the second-line drugs in the treatment of scleroderma Raynaud's. So what I'm trying to tell you with this paper, this is not I won't say it is a landmark paper at all, but it is important for us from Indian perspective, because all of us have been depending on this 4.3% and another 1% from Europe to data coming from these areas. But let us look at 18% of world population living in India. Let us produce data. At least in scleroderma, or any other field, Indian rheumatology has been producing doing a lot of research, and we have to help. We have to do research ourselves, collect our own data, and publish. And Indian Rheumatology Association with Alakendu sir at helm of affairs is here to support all of you. So please submit some research protocols and do your own research, and let us. And we are sure when you guys another 5 to 6 years from now, these fellows who come out and do research, we will definitely at a much better place, and will be make our nation proud by doing our own research. Thank you for patient listening. Although it was not landmark, I thought I should convey this message to fellows that research is extremely important and we should be doing our own research. Thank you for patient listening.
Thank you, Dr. Padmanabhan, for your, as usual, lucid and illustrative talk. As I said earlier, you have justified my saying that seek, learn, serve is your motto. And your speech was riddled with so much of exciting factors, your own observations, comparison with the other country trials, and you have proved by your clinical practice that you are a poor-man's rheumatologist. So probably you have compared mycophenolate mofetil with the cyclophosphamide, and in all your studies, all your pointers, you have made it out loudly clear that cyclophosphamide is no way less inferior to mycophenolate mofetil. Maybe it falls short in certain areas. Very good, very good presentation. And as you said, we focused mainly on fibrosis, it's a fibrotic condition, nothing can be done. You said it's deadly. It is more dreaded than deadly because people are very much afraid to face the disease, and we should be more sympathetic, and we now focus on the controlling the inflammation, which controls the fibrosis ultimately and improvement in the lucid presentation. The questions, any questions?
Damodaram has asked, very good suggestion. Lung transplantation,
Yes,
bad
yes.
ILD without PH in scleroderma or any other CTD. Early lung transplantation, late lung transplantation, can we avoid heart lung transplantation if we do it early in lung transplantation, bad ILD? See, lung transplantation is one of the last choice if you don't respond to all this. So my experience and world over experience, my experience is a big zero. Lung transplantation, what people say is that you have when Dinesh Khanna and others when they came to Kochi, so I was speaking to them. So what they say is lung transplantation in India is still in infancy. In UK also it is being done at a bigger scale, but the results are still not up to the mark. So that's what they say. If somebody has a FPC of 90 and it drops to 80 or 70, directly go for bone marrow transplantation. That is much safer and will give you a much better outcome. Lung transplantation, yes, it is an option definitely when in end-stage lung disease, and definitely you can. Recommended injection dose of mycophenolate, duration of injection of 1 year or 6 months. See how this index, the boundary of induction and maintenance is always arbitrary. Whether you have to change from induction to maintenance, when should you change? 6 months to 1 year is the rough outcome I would keep. When do you say that induction is successful? That is the first thing. Induction is successful when you are able to stabilize the disease or improvement in FVC. Improvement doesn't happen in everybody. So for example, if there is a 60% FVC, if it is stabilized at 60 or 62, 63, maintained around 1 year, you say that your induction is over and you can switch to maintenance phase. So for MMF, it is very easy because from MMF after 1 year, you can slightly decrease the dose. In cyclophosphamide, it is slightly tougher because you may have to find another agent, because giving cyclophosphamide more than 1 year can cause side effects. Duration of maintenance therapy, our study showed that at least you have to immunosuppress for 5 years. In our paper, we have patients who are on leflunomide, we have patients who are on methotrexate because they had severe arthritis and they were not affording mycophenolate or azathioprine, so they had to be put on methotrexate and leflunomide. So the most important point is that not the what drug you give. It is extremely important whether you are stabilizing their disease and keeping their FVC in the tight control. Isolated skin tightening in diffuse scleroderma, I find methotrexate useful. If methotrexate doesn't work, mycophenolate has the best result. Cyclophosphamide I usually don't give because it has to be given for longer time. But cyclophosphamide also works. If it's a very early disease, if it's a male more than 40 years, cyclophosphamide also stabilizes the disease well. Majority of scleroderma patients have body weight less than 40 kg. What will be the best tolerable dose of MMF? I didn't put up my this thing. It's a very good question, Vignesh, because we did a pharmacokinetic analysis, which was just analyzed last week. All our patients had a mycophenolate levels higher than what is expected. With even 2 grams, most of our patients had a toxicity levels of 65 to 70, area under the curve. And what we showed was that our study was basically, we gave mycophenolate in combination with the ranitidine or esomeprazole. Once you give the proton pump inhibitors, the level of mycophenolate falls by around 40% or 50%. So the first point, you always give them at empty stomach and never combine mycophenolate with pantoprazole or ranitidine because it will come down, decrease the drug level. Second thing is, what is recommended in West may not be required for our patients. We may do with lower dose. Your experience in BMP in scleroderma, 0 till date. So I don't think, I think only a couple of, there are 5 or 6 cases in R&R has done the bone marrow transplantation and it is reasonably good results. They have published their data also. Dr. Vivek has published. Vasudev Vivek and his group.
Now let us conclude the session with Dr. Padmanabh Shana's very informative talk, and let us proceed on to the next panel. I welcome our National Secretary, Dr. Sapan Pandya. Good evening, sir. And Dr. Sapan Pandya, apart from being a Secretary of Indian Rheumatology Association at present, he is now a faculty at Municipal Hospital, Ahmedabad, And now we are going to a panel. Is going to be a moderator for the. And I would like to pass a few comments, short comments. I got introduced to Dr. Sapan Pandya in last year's retreat at CMC Vellore, and his humor was boundless, and he was so charismatic, and he was so humorous and full of wisdom. Hats off to you, sir. And sir will be the moderator for the session on Sjogren's syndrome. The participants panelists being Dr. Anu from IPGMER, Dr. Upendra from SGPGI, Dr. Arun Baby from NIMS, Dr. Mahabaleshwarar from MMC or college, and Dr. Prasanta from Gujarat, and Dr. Monish from Gujarat. Now, over to Dr. Sapan Pandya.
Thank you, Professor Tamil Selvan, for the kind words. I'm not sure about the wisdom. I'm more sure about the humor part, and so thank you first of all, Professor. I don't think I'll thank myself because it's the president and secretary who has done. But I must say here that this program has entirely been conceptualized by the Kolkata Medical College, and I've said this before also that in parts I think this program seems to be even better than the IRA webinars, I must say. And just because there are too many webinars, it becomes difficult to attend. But I think these are really useful ones. And therefore, when we had less scholars joining in, and this is a sort of a pseudo warning to all the scholars that if you don't join, we'll open it all to the IRA members also, because this stuff is really. One suggestion I gave Argo was to try and tap the MD residents, especially your college who are interested in rheumatology. This should be useful for them also. And you can get the list from the Deodhar quiz, because I was doing that earlier. They have the list of all the medical colleges in India. And so at least the postgraduates of who are interested in rheumatology, they can, it might be a little too much for every MD, but that if our scholars don't join, I think that is one thing that we could do, and also open it to IRA members. I'll leave the introduction part to each student himself. I know where they're from, but it's best that they speak about themselves. So I think we'll, so what I've done in the next 1 hour or so, I was asked to keep more practical stuff. So it's just 6 cases, which case scenarios which we see day in and day out for Sjogren's syndrome, and we'll just discuss one by one. Of course, you can't discuss everything, so some of it might be left out, but I'll try and make it as interesting as possible. So can I have the first slide, please? Yeah. So this is more for us than for scholars, actually. That clinical expertise comes not only from experience, but from a commitment to lifelong learning. Establish these patterns in your daily and monthly routines and plan to carry them beyond graduation day. This is something for all of us who have graduated. Remember this, this is a message to all the scholars, that your training doesn't end here. It actually starts. So you have to keep yourself constantly updated, make an effort to do that. Once you are out from your institutes and into your areas, it'll be very important to make your own sort of timetable where you regularly look at stuff to update yourself. So this is going to be the most important message from me. Can I have the next slide, please? Yeah, so we'll have 6 different case scenarios, I said, on presentations of primary Sjogren's syndrome. So first, I'll put up this slide for the case scenario, and then will be the presentation by the panelist. After the presentation is over, and we have roughly 10 minutes for each case, and we have about, I think, total about 65 slides. So maybe 1 minute per slide. I request each panelist to keep the speed accordingly. Comments by any panelist or from me. Let me say here that we are all the same. There are no experts here. There is no crew. Everybody is a passenger in this airship. Question and answer through the chat group. I'll be looking at that, and Argo can help me there. So any questions which are there, we'll try and answer. If there's no time left, we'll take it up later. And then conclusions at the end of the sessions of what are the broad conclusions of this presentation. Now the next slide, please. Yeah. So the first case scenario is a 50-year-old lady who comes with sicca, dry eyes, and dry mouth only for 2 to 3 years. So she doesn't have anything else. This is one of the most common presentations that we see. There are no other complaints to, and to discuss, the panelists will hopefully discuss the differential diagnosis of sicca, the classification criteria of sicca, how it has evolved over these years, and diagnostics of sicca, dry mouth and dry eyes. What are the available tests? Because sometimes we find very difficult to do the salivary test done by the dentist here, and something about ultrasound, parotids, and MRIs, which have recently come in the last few years. So I now call upon the first panelist, Dr. Mahabaleshwar.
Yes, sir.
You can introduce yourself and start your.
Good evening, everyone. I am Dr. Mahabaleshwar. I am a first year rheumatology PG from Madras Medical College, Chennai, and I will proceed with the case, sir. We have a case of a 50-year-old female who has a dry Zika symptoms of eyes and mouth since 3 years and no other complaints. First approach to Zika, we need to know the duration of symptoms of Zika. More than 3 months should be okay with us. And later, the patient may present with various signs and symptoms. If it is a dry mouth, the patient can present with soreness, decreased salivation, dysphagia, and dental caries. And on examination, the patient may have dental caries, angular cheilitis, deep appellation of the tongue, and the surface of the tongue may be red, lobulated, and we need to look for Candida infection. And patients having dry eye may present with foreign body sensation in the eyes, grittiness of the eyes, and they may present with decreased visual acuity, conjunctivitis, blepharitis. And other symptoms, we need to ask about dyspareunia, vaginal pruritus, pruritus in the ear. Now, coming to the symptomatology of dry eye or keratoconjunctivitis Zika. It may be because of the patient may have normal TL production with dry eye. The main causes being environmental factors like secondary to air conditioning, smoking, computer work, meibomian gland dysfunction, contact lenses, and corneal hypoesthesia after LASIK surgery, and reduced ear production secondary to drug-induced like anticholinergics, antihistaminics, tricyclic antidepressants, diuretics. And as the age progresses, they may also have dry eye. And in patients with post-head and neck irradiation and chronic viral infections like HCV, HIV, sarcoidosis, lymphoma, Sjogren syndrome, and IgG4-related disease. And other causes of xerostomia being, it may be again drug-induced, as told earlier, or anxiety disorder, endogenous depression, fibromyalgia, and status post-head and neck irradiation, and secondary to some systemic disease like sarcoidosis, amyloidosis, HCV, HIV. Next slide. Now, coming to the comparison of classification criteria for primary Sjogren syndrome. As you know, the classification criteria has evolved over 30 years. And here, initially it was first proposed in 1980, later 2002, 2012, 2016. Now the latest is 2016 acellular criteria. Here, there are prerequisites before scoring the patient for a Sjogren syndrome. The patient should satisfy some prerequisites. That is, he should have at least one positive domain from European Sjogren syndrome disease activity index, and also he should have at least one Zika symptom, that is dry eyes of at least 3 months, or dry mouth of at least 3 months, or at least if he is using a tear substitute, at least he should there should be using the tear substitute for at least 3 times a day. And there is some exclusion criteria. We should rule out active hepatitis C, sarcoidosis, HIV, IgG4 disease, and the chronic graft versus host disease. Once these all things are set in, then the scoring system, that is salivary gland biopsy, that is a focus score of 1 per 4 mm square. It is given a score of 3. And serology, anti-Ra antibodies is given a score of 3. And oral signs, unstimulated whole salivary flow of less than 0.1 ml per minute is given a score of 1. Ocular signs, Schirmer's test, less than 5 mm staining of the filter paper in 5 minutes, score of 1. Ocular staining, score of 1. Now, what are the modifications in 2000 ULR criteria? As you see here, the Zika symptoms earlier, the Zika symptoms are now considered as a prerequisite for classification criteria rather than a scoring system. In 2012 and 2002, they were a part of the scoring system. Now they are prerequisites. And serology, as you can see here, only anti-Ra is used in 2016. Anti-La was not included because it was found that in patients who were anti-La negative and anti-Ra and anti-La negative, the clinical features did not vary, and hence anti-La was not used in the 2016 acellular criteria. And other features being psilography and scintigraphy was omitted from the 2016 criteria. Also, IgG4 disease was first included in the exclusion criteria, and lymphoma was removed. And as you know, active hepatitis C should be ruled out by the PCR advanced tests in the exclusion criteria. And ACR Euler criteria 2016 has a sensitivity of 95% and specificity of 96%. Evaluating the main salivary glands. Now we have unstimulated salivary flow rate. That is, we need to ask the patient to spit in a container for at least 10 minutes. Usually, it should be if it is less than 0.1 ml per minute. That is, if the salivary flow is less than 1 ml for 10 minutes, then it indicates that the patient is having Zika symptoms. But this is not a good test, because as the age progresses, the patient may have decreased secretion. So the better test would be stimulated salivary flow. Now we will stimulate the secretion with the chewing gum or lemon juice, and this has better correlation with the histopathological results or structural glandular damage compared with the unstimulated salivary flow rate. And salivary scintigraphy, it assesses the function of the salivary glands. It is a non-invasive quantification of uptake and secretion of technetium-99 by the salivary glands. And remarks, severe involvement at diagnosis is associated with higher systemic activity and poor outcomes. Having evaluated the salivary glands, now we will evaluate the lacrimal glands. We have mainly 3 tests: Schirmer test 1, Schirmer test 2, and corneal stainings. As you know, Schirmer test 1 will measure the baseline plus reflex secretion, and it is done without anesthesia. And Watman paper number 41 is used for staining. And Schirmer test 2, here the anesthesia is used and it evaluates the baseline secretion. And regarding the corneal staining, fluorescein and lissamine is used. Earlier we have rose Bengal dye, but this rose Bengal dye was not available worldwide and it was also painful. Now in the new criteria, they use fluorescein and lissamine. Now fluorescein is used for staining the cornea. As you can see in the left hand image, multiple defects in the epithelium of interpalpebral cornea are evident as fluorescein staining dots. And in the right hand, you can see a triangular area of staining of the interpalpebral temporal conjunctiva. It is lissamine green staining of conjunctiva. Now, ultrasound of the salivary glands. Ultrasound is a cheap modality and a widely available modality, and it has sensitivity of 60 to 90% and specificity of over 90%, almost on par with salivary gland biopsy. First, normal salivary glands are uniformly hyperechoic and homogeneous tissue. In Sjogren syndromes, in the early stages, the gland becomes edematous because of the inflammation, and it may become hyperechoic. The parotid glands may become enlarged to around 20 mm. Whereas in the late stages, it may characteristically show a multicystic or reticular pattern with an atrophic gland. The submandibular glands may become atrophic. Here in this image, you can see the ultrasound of the parotid gland. On the left hand side, you can see the pro-positioning of imaging the left parotid gland in the longitudinal section. On the right hand, you can see the left submandibular gland in a transverse section. In a normal ultrasound, it is usually hyperechoic and homogeneous. Whereas here in this slide, you can see ultrasound evaluation of a patient with Sjogren syndrome. Here you can see the typical hypoechoic areas in both the images. Now MRI of the salivary glands. Again, MRI, in the early changes, there may be inflammation and swelling, whereas in the late changes, there may be some multicystic changes, fibrosis, and parotid gland involvement may give a salt and pepper appearance or a honeycomb appearance, which is evident in this MRI image. And also, because of its high spatial resolution, MRI is most useful imaging technique for local staging of the primary Sjogren syndrome associated with salivary and lacrimal gland lymphoma. Summarizing, for whenever a patient presents with Zika, ask for a history of symptoms like more than 3 months, followed by applying the primary Sjogren syndrome criteria. Look for the signs and symptoms of dry mouth and dry eye, and later try to look for the prerequisites, exclusion criteria, and then the Euler classification criteria for Sjogren syndrome. Thank you.
Thank you, Dr. Mahabaleshwar. There is just one question. We'll first take up, I think, by Dr. Upendra on why antibody got higher priority as compared to other objective tests of Zika in your criteria. You want to take that up, Dr. Mahabaleshwar? Or?
Yes, sir. Yes, sir. Because it was found that in patients who were anti-LA negative and also anti-LA positive, and patients who were both anti-Rho and LA negative, the clinical features did not vary much. Hence, anti-LA was given less preference and only anti-Rho was considered.
Yeah, I think what he means is above the not above law, but above objective, other objective like the Shermas or the other tests. I think it's primarily because of an increase in sensitivity. If you look at the earlier criteria, they brought in ANAs and rheumatoid factors also because people are missing cases of Sjogren's syndrome. And then there is always a gating strategy before. You have to ask those questions, and only if those patients who have those symptoms, if the anti-Rho is strongly positive, then that becomes very likely to be Sjogren's syndrome. Earlier, Rho was considered to be a chaperone, it still is, but more and more we are finding anti-Rho associations with clinical syndromes. I think the more they identified, the more the importance of anti-Rho is getting along. That is the only possible explanation. The second case is a 55-year-old lady with dry eyes for 10 years. Severe pain and grittiness increased over the last 1 month in one eye with decreased vision now over a few days. She has dry mouth, also very severe, and joint pains over the last 2-3 years. So I would want the panelists to discuss on treatment of Zika. And I think it's going to be Dr. Arun Baby from NIMS, from Nizam. Any role of immunosuppression in Zika? Something that there's always that controversy, evidence or lack of that. How to manage refractory Zika? Any promising drugs and management of corneal melt? Please.
Good evening, respected faculty and my dear colleagues. What are the available topical solutions available for this Zika? First, coming to the ocular Zika, we have artificial tear substitutes that contains mainly of carboxymethyl cellulose, that's 0.5%, then polyvinyl derivatives, 1.4%, chondroitin sulfate, and sodium hyaluronate, which is 2.3%. Along with that, we have non-steroidal anti-inflammatory drugs like dicyclophenac sodium, 0.1%, and ketorolac, 0.4%. And topical glucocorticoids, which include prednisolone, 0.12%, and fluorometholone, 0.1%, and dexamethasone, 0.1%. Then coming to those who have more severe symptoms of dryness, we can use topical immunosuppressants like topical cyclosporin, 0.05%, topical tacrolimus, 0.1%, and even oral muscarinic agonist like which is widely used, pilocarpine can also be used. And about the oral Zika, for the mild granular dysfunction, we can use non-pharmacological agents like gustatory stimulants like sugar-free acidic candies, lozenges, xylitol. And for the moderate granular dysfunction, we can use pilocarpine. For non-responders to these muscarinic agents, some mucolytic agents like bromoxin and N-acetylcysteine can be used. And now coming with recently saliva substitutions, which mimic the natural saliva, we can use, they are of a neutral pH and contains fluorides, thus even preventing cavities and other electrolytes. And what are the, have immunosuppressants any role in the treatment of Zika syndrome of Sjogren's? Actually, according to the ULR recommendation of 2019, according to the SLR studies for the treatment of ocular and both oral dryness, hydroxychloroquine, there was no placebo difference for the subjective and objective ocular and oral outcomes in the pivotal RCT, or neither did oral glucocorticoids or immunosuppressive agents, which had an overwhelming negative results with side effects, or rituximab, where there was no placebo difference between subjective and objective ocular and oral outcomes in the two pivotal RCT and meta-analysis. And what is the promising drug that is in the pipeline for this Zika syndrome? There are many trials going on with the studies are going on with abatacept. Then there are studies that going with anti-TNF molecules, low dose. And one of the promising drug is this new molecule, which is Escalimib, which is a fully human and humanized human antibody that blocks the CD40, which is a co-stimulator protein involved in the activation of immune B cells, which are crucial for the development of Sjogren's syndrome. This immune interaction mediated by the CD40 coupling to another protein called CD154 are thought to contribute to the inflammation and salivary gland infection and other kind of tissue injury linked to the disease. And coming to refractory ocular symptoms, how do we manage? As the artificial tears and ointments will be the first line of medicines in all. Those who don't respond to it, we along with artificial tears and ointments, we use topical glucocorticoids. Still, if there is no response, there we go to topical cyclosporin, and there is also use of autologous serum eye drops, which is from the patient's own serum. And even to this, if there is no response, we can use oral muscarinic agonist like pilocarpine, cevilimine, and even going further ahead by this plug insertion. Then coming to refractory oral symptoms, like just said before, the non-pharmacological agents which use chewing gums which are acidic, and coming to pharmacological agents, use of pilocarpine and cevilimine, then salivary substitutions, and even use of mucolytics like N-acetylcysteine and bromhexine, and chloretic agents, and lastly, by electrostimulation. And treatment of corneal melt. Since corneal melt is one of the dreaded manifestations in not only Sjogren's and we've seen in other conditions, many infections, the treatment includes, for mild cases, tissue adhesives like cyanoacrylate can be used to close small perforation up to 3 millimeter in diameter, and may even slow down the stromal melting. Other treatment options for corneal melting and perforation includes medical therapy of the underlying disease and simple measures like bandage corneal lens, corneal gluing by using cyanoacrylate, and tassoraphy. And if these methods fail, we can use the use of conjunctival flaps, amniotic membrane transplant, lamellar keratoplasty, deep which is could be superficial or deep lamellar keratoplasty, patch graft, or penetrating keratoplasty. Thank you.
Thank you, Dr. Babu. I don't just one couple of things I wanted to say, that it's very important to remember the preventive measures also, like wearing glasses which are sort of broad, and there are those lenses which you can wear. Avoid air conditioned climates or very hot climates. Important for dry, simple basic things for dry mouth, avoiding sugar containing and keeping your mouth moist in ways, and using those brushes which also take care of the interdental stuff. So those are things again which you not forget. Regarding the corneal melt, in if it's vasculitis, you have to differentiate between if it's an abrasion because of an extremely dryness of the cornea which has become very thin. In that case, you of course treat the dryness. But if it's a vasculitis, which means corneal melt in rheumatoid, for example, you get secondary. It's a sign of a vasculitis, and if it's in the very short term, the patient has started losing vision, then you have to treat them as a vasculitis and treat them with immunosuppression, try to salvage the eye. Now, you don't require heavy immunosuppression as was taught earlier when we did my DM in all cases of these. But corneal melt does become an emergency, and you have to give them immunosuppressants to try. And so it's best to coordinate with the ophthalmologist and treat these patients accordingly. I think with that, we'll take up the next case, please. Yeah. So this is a 30-year-old lady with recurrent dependent purpura over lower limbs since the age of 18 years, no sicca parotid. Joint pains will last 1 to 2 years with early onset symptoms of 45 minutes, no swelling though, total serum proteins are 10, so she has raised globulin. To discuss the differential diagnosis of such a kind of purpura, you can see in the adjoining figure how to differentiate from vasculitis, is biopsy needed in such cases, management of purpura, and does asymptomatic hypergammalobulinemia need to be controlled, and how? And I think to address this, we have Dr. Mohnish Patel.
Yes, sir.
Yeah. Go ahead, Mohnish.
Yes. Good evening, everyone. Thank you, sir, for this opportunity. I am a junior fellow doing my fellowship under Sapan sir at Ahmedabad. So I'll directly start with my case. Next slide, please. So the first question is how to approach for dependent purpura in such cases. So the first thing is we need to differentiate between non-palpable and palpable purpuras. The first thing we look for always is bacterial infection, which can present in both the categories. The other is looking for other causes of thrombocytopenia, which can be common in viral fevers like dengue fever. The third category would be to look for DICs as one of the causes of such kind of dependable purpuras. stasis is common for both kind of palpable as well as non-palpable purpura. So look for any causes for stasis. So we need to dig deep into the history of the patient. Any drug reactions causing this, and cryoglobinopathy is responsible for both palpable as well as non-palpable purpura. As far as vasculitis is concerned, it will almost always present with palpable purpuras. Bacteremia, again, as I told, is common in palpable category as well. And when we talk about vasculitis causing purpura in Sjogren syndrome, then we need to eliminate IgA vasculitis, leucoclastic vasculitis, which is the most common presentation in Sjogren's, and granulomatous vasculitis is the most common etiology. So the question was how to differentiate clinically whether it is vasculitis or vasculopathy. So we should first look for palpability. Due to inflammation in vasculitis, it is almost always palpable. So that is one pointer towards vasculitic etiology. If it is polymorphic, it goes more towards leucoclastic vasculitis. So that is another pointer. And during evolution of purpura, if we dig deep into the history of the patient, then if the purpura is dark, that is non-erythematous, it has never been palpable, and it evolves into necrotic lesion without undergoing an erythematous manifestation, then it is most likely vasculopathy and not vasculitis. So these three can be an indicators of vasculitic etiology. So this was an Italian study done. This was basically for, it was specific for Sjogren syndrome induced vasculitic purpura. So the two most common causes are cryoglobulin induced vasculitis and hypergamma-globulin induced vasculitic purpura. So the results were, they had divided about 650 Sjogren syndrome patients into three groups. First is the cryoglobulin group, the other one was the IgG group, and the third was the control. They wanted to look for clinical as well as biological components. Are there any different in their presentations over time? So the cryoglobulin group, they developed lymphomas, peripheral neuropathy, again secondary to the vasculitic component, and the renal involvement, that is glomerulonephritis due to vasculitis. That was significantly more in the cryo group as compared to the gamma globulin induced vasculitic purpura. So these are the parameters which we may want to keep in mind while during the follow-up of such patients. The next question was, do we need a skin biopsy while managing such kind of a patient? So the advantage is it is very easy to perform. For purpura specifically, we only need superficial tissue. We need not go to the fat layer, and there won't be any aesthetic issues also in the lower limbs. But the disadvantages are the findings on a skin biopsy in purpura, they are not specific for Sjogren syndrome, so not useful for diagnosis. And the biopsy scores or specific findings also, they do not decide treatment regimes in Sjogren syndrome. So if clinically we are sure, of the diagnosis, then biopsy will not add on to our decision making. And for leucoclastic vasculitis, it is the most common prevalence in terms of the etiology of dependent purpura in Sjogren's. So this is the classic presentation on biopsy, where we have a small vessel involvement. There is extravasation of the red cells and surrounded by mononuclear and neutrophil infiltration with neutrophilic dust. The third was the management of purpura and hypergamma-globinic state. So this is the EULAR task force. They had published in 2019 specifically for Sjogren syndrome. So when we talk about management of Sjogren syndrome by immunosuppression, the first thing we need to consider is the mortality and morbidities. As compared to healthy cohort, mortality is worsened only if they develop lymphomas and the extraglandular manifestations are severe enough. So that forms the basis of consideration of treatment, specifically when we talk about immunosuppressing the patient. Based upon this, this task force gave these two recommendations that overall disease activity should be at least 14 or more according to the SDI domains, or if any of the domain has got a severity index of the third level, that is the severe, which is not present in our case that was discussed initially. One more, please. Our case actually falls in this moderate SDI category, which is a limited purpura. So I had calculated the SDI for this patient that turned out to be 10. So based upon this, she neither has a severe disease activity nor diffused vasculitic involvement or any ulcerating lesions. And also she is treatment naive as such. So for our patient, we can first try only with NSAIDs if the frequency of purpuric episodes is not that problematic and the arthritis is also manageable by just painkillers. If the frequency does increase and there is significant arthritis, then we can consider a short course of low dose glucocorticoids that is in the range of 0.3 milligram per kg per day. We can add hydroxychloroquine or methotrexate for the arthritic component and then quickly taper off the steroids. This basic chart is for the recommendations and the overall principles we need to consider before we start immunosuppression. So no need to go in all the details. This was also given by the same task force based on the level of evidence and the grade of recommendation. So my basic point is the summary is, as far as managing a hypergamma-globulinic state in Sjogren's syndrome is concerned, there is no mention of any requirement of treatment. So we should not be treating these type of patients. So I'll conclude with this. As far as management is concerned, for purpura part, we have two options. First is the aggressive approach with immunosuppression. We need to take this approach only if it is diffused, which is not our case. It should be ulcerative or involvement of neuropathy or glomerulonephritis secondary to this vasculitis, which are indicators for life-threatening disease eventually. Or we can go for conservative treatment of NSAIDs or low-dose short course of glucocorticoids. And the second component of the question of the hyper-IgG state, it should not be treated definitely if it is asymptomatic. Thank you.
Thank you, Dr. Monish. So there are two questions. One is, and it's Upendra asking almost all the questions. So one is, would you call this really Sjogren's syndrome, or would you just call this Waldenstrom's hypergamma purpura?
Yes, we need to first the ANA profile and everything must be done for the basic workup of the patient before labeling it as Sjogren's syndrome. And without SICA, it is always difficult to label the patient as Sjogren's.
Yes. So yes, this is Waldenstrom's hypergamma purpura, and see, because if you look at the gating strategy itself, it has SICA in it. Again, an important thing to remember is that those are classification criteria, not really diagnostic criteria. But without SICA dryness, it would be very good. And we put these cases purposely because these are situations which we face day in and day out. If these patients, as Monish says, were anti-Rho strongly positive, they are probably formed first a Sjogren's syndrome and could later evolve into them or not. But as he said that we would treat the symptoms, and it's always best to go by syndromic diagnosis. The other question is rule of Colchicine. Are you aware of any data on the Colchicine? And so
yes, sir. There are case reports and case series, sir. But the task force has clearly told only to be treated only if it is diffused, otherwise not to be treated.
Yes, so there is data on colchicine in these, but the bottom line here is that as Monish clarified, that if you have recurrent purpuras and you have high globulins and high ESRs, there is this tendency to overtreat these patients. But it is important to know that we don't treat the reports and we only report the symptoms. So you could just advise stockings and leg elevations and symptomatic stuff. Maybe colchicine for a short while. I wouldn't contemplate using it very long term. Maybe, and drugs like hydroxychloroquine, which there are some trials which have shown, but certainly not very aggressive treatment in such cases. So that's what we wanted to share. So can we move on to the next presentation, please? Yeah, so case number 4, and I think it's going to be Dr. Anup Matthews from IPGMER to answer this. There's a 40-year-old lady has had recurrent hypokalemic palsy. Again, another thing that we commonly see for the last 10 years, at least 3 to 4 times, recurrent parotitis too from the same duration. She has SICA and severe pain over both thighs for the last 1 year, has fractured multiple times over the last 3 to 4 years without trauma. And to discuss renal tubular acidosis in Sjogren's, how to diagnose, whether you need to biopsy every kidney in such cases, and how to manage these, would immunosuppression be needed? Again, something that we are always confused about, and management of the metabolic bone disease issues. Dr. Anup.
So good evening, everyone. I'll be presenting the renal involvement in Sjogren's syndrome. Myself, Anup Matthew from IPGMER, Puducherry. I'm a DM second year resident. Okay. So we have a 40-year-old lady with recurrent hypokalemic palsy for about 3 to 4 episodes in the past 10 years. In addition, she has recurrent parotitis, oral and ocular sicca, and she also complains of severe pain over both eyes for the last 1 year, and had recurrent fracture of bones without any severe trauma. So she has, here we have a 40-year-old lady with recurrent parotitis with sicca symptoms with hypokalemic periodic paralysis and recurrent pathologic fracture. So primary diagnosis I would like to give is primary Sjogren's syndrome with the differentials of sarcoidosis, IgG4-related disease, and HIV associated ALS in mind. Next slide, please. So investigation-wise, I would like to do CBC with smear to look for any anemia or thrombocytopenia. Then a complete biochemistry panel to look for hypokalemia, any renal derangement, elevated muscle enzymes, then hypergammaglobulinemia, hypocalcemia, hypophosphatemia or diabetes. Then urine examination for any active urinary sediments or proteinuria. Then viral markers, particularly HIV and anti-HCV, which can mimic Sjogren's, and ANA, expecting a speckled pattern. Then serum vitamin D levels to rule out vitamin D deficiency, or IPTH to rule out hyperparathyroidism, and TFT4 to rule out any dysthyroidemia. Then Schirmer 1 and 2 for objective evidence of sicca. Blood gas analysis for metabolic acidosis. Then chest X-ray PA for any lymphadenopathy, abdominal X-ray erect for any renal stones. Then X-ray, other limb X-ray and pelvic X-ray for any osteopenia or loose stones or fractures. Then DEXA scan for any bone density and MSGB and renal biopsy if indicated. Next slide. So coming to the renal involvement in Sjogren's syndrome, the most common pathology finding is tubular interstitial nephritis. So here any segment of nephron can be involved. Depending on that, we have a distal RTA, which is the most common among these, and then proximal RTA or Fanconi syndrome, diabetes insipidus, acquired form of Barter's or Gentleman syndrome, and rarely glomerulonephritis, particularly with triaglobulinemia vasculitis. So when to suspect RTA? So an RTA patient can present with multiple symptoms. They can have polyuria, periodic paralysis, renal colic due to nephrolithiasis, aches and pains, which may be due to osteomalacia or pathologic fractures. So in a Sjogren's syndrome patients with multiple aches and pains, before labeling them as fibromyalgia, we should look for other organic causes. So to establish a diagnosis, in a blood gas analysis, we can have a normal anion gap metabolic acidosis with hypokalemia and hyperchloremia. Then urine pH is usually elevated and more than 5.5, and a positive urinary anion gap. So coming to next slide, please. Coming to the role of renal biopsy in renal tubular acidosis. Okay. Routinely, it is not recommended, but with special indications such as impaired renal function, without any other cause such as drugs, then significant proteinuria of more than 0.5 gram, active sediments, or when we have a doubt of in the diagnosis, to exclude other diagnoses such as IgG4-related disease or lymphoma, which can also present with RTA. We should go ahead with renal biopsy. Next slide, please. The most common pathology finding that we get in renal biopsy is tubular interstitial nephritis, following which we can have MBGN, secondary to granulobulinemia. We can also have membranous nephropathy. IgA nephropathy is also associated. Next, please. Then we can have FSGS, minimal change disease, unspecified proliferative glomerulonephritis, corresponding glomerulonephritis, and global glomulosclerosis. Next slide. So people have treated these conditions with immunosuppressions, and they have found that treatment with steroids or other immunomodulatory therapies has got a better disease outcome in the form of either remission of disease or improved renal function or a stable disease. So previously we were thinking like interstitial nephritis is usually a benign disease, but it need not be benign always. But whenever there are indications or hard findings, we have to go ahead with the biopsy and treat them with immunosuppression. Next slide. So coming to the treatment of renal tubular acidosis in Sjogren's syndrome, symptomatic hypokalemia should be treated with lifelong potassium citrate with sublimation titrated based on the blood gas analysis levels to target of more bicarbonate more than 20 to 22. So alternatively, a cheaper option will be soda bicarbonate with KCl. Then dosing, if bicarbonate is more than 16, we can go ahead with 30 milligallon of citrate or bicarbonate twice daily. When it is less than 16, we have to give an equal dose 6 hourly. So persistent hypokalemia, we can add potassium sparing diuretics, and immunomodulation may be indicated when they have moderate SDI. We can go ahead with 0.5 mg per kg of prednisolone equivalent of steroids, plus along with steroid sparing agents such as azathioprine, cyclosporine, or MMF. When the when SDI is high, we have to go ahead with higher dose of steroids with cyclophosphamide, rituximab, or PLEX. I have kept the reference for classification of moderate and high SDI in the insert. Next slide. Next slide, please. So coming to the metabolic bone disease and Sjogren disease. So before treating, we have to rule out other causes which can cause similar manifestation. So we have to rule out vitamin D deficiency. If present, we have to correct. Then we have to look for any hyper or hypothyroidism. If present, we need to correct that as well. And chronic metabolic acidosis can result in hypercalciuria, hyperphosphatemia, and it can itself increase the bone resorption. So all these can reduce the bone strength. So we have to correct this. And acidosis need to be corrected with by replacing bicarbonate, as mentioned earlier. Then calcium and vitamin D supplementation and correct phosphate deficiency if present. So then anti-resorptive therapy, we can go ahead with bisphosphonate. The one thing which is cheaper and easy to administer is zoledronic acid 4 mg infusion, which can be given yearly. Other alternate oral options are ibandronate 150 mg monthly, and alendronate and risedronate, which need to be given weekly. So refractory cases, we can go ahead with teriparatide 20 micrograms sub-Q daily for 6 months and up to 2 years as an anabolic agent. Thank you.
Thank you.
And calcitonin may be used for pain relief in case of regenerative fracture.
Thank you, Dr. Anup. So there is this one question again from Upendra asking if you would still go for a biopsy in nephritic range proteinuria with no active sediments.
If it is persistently elevated, then I would like to go with biopsy.
So normally just we don't, if this is one report, then you normally don't do it. The indications for biopsy, the threshold is slightly higher than we do in lupus. We almost biopsy every case. In most of Sjogren's cases, you don't need biopsies unless as such a case that you pointed out, and if there is a persistent problem. And most of the times, as Dr. Anup said, the nephrologists have taught us to manage these cases with just potassium citrate and the alkali treatment. But in refractory cases, and I remember one case at least we had in our teaching hospital who kept having these, and then when we did the biopsy, we found inflammation evidence. And so if you look at the case reports, people have used immunosuppression. In that particular patient, we had to give him rituximab for other things that she had, parotids and those, and she improved in terms of RT also. But normally, we don't do a biopsy if the patient is static and is improving or is maintained, and we don't give heavy immunosuppression at these cases. There was one more question from last, it came a little later, of how to, if the globulins are high, how do you monitor those cases? And so while there are no recommendations there, what we generally do is every 3 to 6, Monish, you want to take it up? Then you can take it up regarding globulins.
Yes, sir. Sir, like so basically what we are doing, sir, is like we are repeating the IgG levels every 3 to 6 months. So in a normal follow-up, we look for the IgG levels as well. The main issue is that we need to correlate clinically with other organ involvements. Because if it is not correlating, then they are very unlikely to further develop into any severe complications or not. So probably based on that, the task force has said that we need not manage them, or we don't need to follow up them very more frequently.
Yeah, so we normally look at the globulins every 3 to 6 months that they come on follow-up. And if there is an increasing level, you are more careful in looking for parotids and lymph nodes and those kind of things. If these are the patients who are more likely to land up with lymphomas, but you don't treat them for them till they really have those issues. So I think next is Upendra, and he'll be discussing this case. Is a 45-year-old lady with sudden onset loss of vision in the right eye and weakness on one side of the body. MRI shows demyelinating lesions. These are MRIs of other patients taken from the net, of course. These are the kind of lesions you find in these patients. No other symptoms of Zika or parotid. To discuss association of anti-Ra with CNS lesions. Are these cases of, again, the same thing, form fruste Sjogren's, NMO spectrum disorders? How common is Sjogren's in these and the other way around? And managing such cases, whether you require cytotoxics or rituximab in these cases. Okay.
Good morning, everyone. In this case scenario, the patient has optic neuritis with demyelinating brain lesions with anti-Ra positivity. And so the first question was, what is the association of anti-Ra antibodies with CNS? As it has already been known that Sjogren's syndrome is commonly associated with anti-Ra antibody, and it has been included in the classification criteria as well. And it is nearly considered to be specific for Sjogren's syndrome. Apart from that, there are multiple studies which have shown that neurological involvement has this was an systemic review which showed that anti-Ra antibodies are commonly associated with CNS manifestations, which can be varied in presentations. So like this, from 1994 to 2014, there are multiple studies which have considerably shown that anti-Ra antibodies are associated with CNS manifestations like this. We can see that in the Alexander et al., the first study, there was a group 1, group 2 who had focal neurological disease and has 48% of patients had Ra positivity in CNS patient as compared to the all patients of Sjogren's, which has 24% of positivity. Apart from that, we can see that there are multiple case studies which have shown considerable positivity for Ra. This was another case. This was another study which showed the association and interrelationship between anti-Ra antibody positivity and the severity as well as the prevalence of neurological manifestations in various subgroups of Sjogren's syndrome. Like in this study, there were 4 groups which were there. The group 1 had CNS manifestations with focal and non-focal, and there was a group 2 who also had CNS manifestations, focal, non-focal, and group 3 there was Sjogren's syndrome patients with no CNS disease, and group 4 where Sjogren's syndrome patients with no CNS disease. And we can clearly see that the percentage of cases who had Ra positivity were more, like 54% of patients had Ra positivity when tested with the precipitating by gel double diffusion, as well as in the group 2, there 53% of cases were positive for anti-Ra when they were tested with ELISA, as compared to the Sjogren's syndrome patients who had no CNS disease, like in the group 3 and the group 4, where the percentage of Ra positivity was considerably less. So these studies have shown that there is considerable association of anti-Ra antibodies and neurological manifestations. In the same study, they've also demonstrated that the severity of neurological manifestations were much more in patients with the Ra positivity as compared to the one with in the patients where Ra antibodies were negative. Like the focal progressive CNS disease was much more, and these abnormal brain manifestations and the vasculitis or the small vessel angiitis were significantly more in Ra positive patients. Now coming to this neuromyelitis optica as well as Sjogren's syndrome, these are the diagnostic criteria. Like for NMO, the diagnostic criteria, the absolute is optic neuritis with acute myelitis, and one more should be present to support it. Either it should be an aquaporin antibody or non-specific or brain MRI findings, which is not fulfilling MS criteria, or non-specific T2 hyperintensity signals. The Sjogren's criteria we have already discussed. Next slide, please. What are the basic mechanisms which are involved in the immune mechanisms which are involved in neurological manifestations in Sjogren's? Are predominantly there is small vessel vasculopathy, cryoglobulinemia, demyelination. They can be antibody mediated, and dorsal root ganglionitis. More or less, there are multiple CNS manifestations which can be seen in Sjogren's, although neurological manifestations per se accounts for about 15 to 20% of cases in Sjogren's, and in that peripheral nervous system involvement is much more likely as compared to the central nervous system. And there has already always been a controversy whether to include psychiatric manifestations as a component of CNS manifestations in Sjogren's or not, because if The definitions of CNS manifestations include psychiatric manifestations like mood disorders, cognitive disorders. The prevalence of neurological manifestations of CNS manifestations increases considerably more as compared to that of the proper brain parenchyma or neurological manifestations. And if we consider CNS manifestations, myelitis, spinal cord dysfunctions, seizures, optic neuritis, MS-like manifestations, stroke, multiple manifestations can be seen in Sjogren's syndrome, although with varied prevalence. There are multiple case reports which have suggested that neurological manifestations often precedes Sitka symptoms, and various reports have reported that it ranges from 33 to 93% of patients who had preceding neurological manifestations and developing Sitka symptoms later on in the course of disease. This was a systemic review which showed that neuromyelitis optica spectrum disorder patients as the initial presentation of Sjogren's syndrome. As we can clearly see that there are nearly 63 cases who had Sitka symptoms with inflammation on salivary gland biopsy. There was Rho positivity, optic neuritis, and NMO antibodies were also done in a few cases which are also positive. So there is a considerably overlap with Sjogren's syndrome and neuromyelitis optica spectrum disorders, or it could be the other way around as well. In neuromyelitis optica spectrum disorder patients, there multiple theories have there are multiple studies which have shown either there is an overlap or they may precede one another. This upper table also shows a systemic review which showed that the Sjogren's syndrome patients and their association with neuromyelitis optica. We can see that all the patients were diagnosed to have Sjogren's syndrome as well as they were diagnosed to have neuromyelitis optica. They can be two autoimmune disease in one entity, or they can be a associated manifestations of the same. And we can see that the aquaporin antibody positivity was also seen in many case series. Apart from that, the lower table showed patients who are diagnosed with neuromyelitis optica spectrum disorder patients with or without Sjogren's syndrome. So we can see that both had similar female preponderance. The age at onset was nearly similar. The optic nerve involvement, the optic nerve plus spinal cord, the brainstem involvement were also nearly similar. But as the initial people had Sjogren's, so the Sitka symptoms were much more as compared to the second group. Similarly, there was not like the anti-Rho positivity, rheumatoid factor positivity, CRP, or was elevated in patients with concomitant Sjogren's syndrome as compared to neuromyelitis optica group without Sjogren's syndrome. This was another study which has shown the serological, the clinical, and the demographic profile of patients who were diagnosed to have neuromyelitis optica, and when we segregate it on the basis of Rho positivity, we can see that the percentage of patients with optic neuritis was similar. Recurrence was slightly bit higher in Rho negative patients, and myelitis was also myelitis on the other hand was more common in Rho positivity patients. And meeting the Sjogren's criteria was 70% in patients with Rho positivity, and they were also met in patients of Rho negativity as well. Now, all the above studies have shown that there is a considerable overlap of Sjogren's syndrome, neuromyelitis optica spectrum patients. This probably can be due to the presence of autoantibodies like aquaporin 4 antibodies are present in astrocytes in the brain, and the aquaporin 5 is present in the salivary glands of the tissues. And due to a homologous sequence of protein similarity, there can be some autoreactive immune cells that can probably be causing an overlap. Further studies further studies are required to further postulate this relationship. And now coming to the management, since according to the EULAR, this patient comes in the severe category group because if we are considering it to be a Sjogren's associated neuromyelitis, then neural involvement, the first line of treatment would be methylprednisolone pulse, followed by we can go for a plasmapheresis. Like in this case scenario, the Rho positivity was there, but it was not diagnosed to have a proper Sjogren's. So I would go with a plasmapheresis if patient is not improving after a methylprednisolone pulse, and then we can try other immunosuppressive agents like cyclophosphamide or rituximab. Cyclophosphamide has already been proved in clinical trials that it has good improvement in patients with neuromyelitis. And rituximab, there are multiple case reports who had shown slight improvement with rituximab, as well as some case reports have shown there is no improvement at all. So rituximab, it is a preserved third line agent. If the patient is not improving after glucocorticoid, cyclophosphamide or plasmapheresis, rituximab would be our third line drug. And if anti-aquaporin 4 antibody was positive in this patient, then eculizumab can also be given. Apart from eculizumab, if we consider it to be a neuromyelitis optica spectrum disorder, other drugs like inebilizumab, satralizumab, which is an interleukin 6 receptor antagonist can be used, or it could or inebilizumab, which is a CD19 inhibitor, can be used. Thank you.
Thank you, Upendra. We don't have any question, but I think the only thing to remember is that some of these white matter hyperintensities are also due to comorbidities, and so
yes, sir, age related. Yes, Sjogren's, as it is a disease of slightly middle aged to elderly people. So comorbidities like aging and cardiovascular risk factors or hypertension, dyslipidemia can predispose to these white matter intensities.
So that's one thing, and of course the differences between multiple sclerosis and these NMO spectrum disorders on the MRI. I think that's one thing that postgraduates should know, but I'll leave it to them to go through. Can we move the last session because we are already running late, please? So this is Dr. Prashant Chotalia going to speak about 28-year-old lady with recurrent parotitis, submandibular lymph nodes, polyarthritis, now has developed a mediastinal and abdominal lymphadenopathy with liver and spleen palpable, has history of purpura, all risk factors, rule are positive. So he will discuss lymphomas in Sjogren's syndrome. Please.
So the lymphoproliferative disease is generally seen in around 5 to 10% patients with primary Sjogren's syndrome, and B-cell lymphoma being the commonest one, and among them, non-Hodgkin's lymphoma is generally seen in around 5% of them. The upper table shows the pooled incidence ratio of non-Hodgkin's lymphoma and various connective tissue disease, and it is estimate of different studies, and it is a meta-analysis, and you can see that the standardized incidence ratio for non-Hodgkin's lymphoma in patients with primary Sjogren's syndrome is around 18.8. And in the below table, it was from the Taiwanese National Insurance Research Database, and they have tried to look at the incidence ratio of overall malignancies as well as hematological malignancies in most of the autoimmune rheumatic disease. And in those patients also, overall malignancy, the standardized incidence ratio is around 1.19, and for non-Hodgkin's lymphoma, it is around 5.13. Regarding the subtypes, majority of them are B-cell lymphoma, and this is data which was published in Scandinavian Journal of Rheumatology recently. They looked at the 105 cases of lymphoma in patients with primary Sjogren's syndrome. 99 among them were lymphomas. There were 6 cases of plasma cell neoplasm. Among 99, majority are B-cell lymphomas. Among B-cell lymphoma, they found that the incidence of diffuse large B-cell lymphoma and the marginal zone lymphoma, which are the mild lymphoma, they found equal incidence. But when they compared the incidence to the general population there, this was done in Sweden, they found that higher incidence of mild lymphoma in primary Sjogren's syndrome patient as compared to the general population, while the incidence of the diffuse large B-cell lymphoma was in proportion with the general population. And when we look at the site of this mild lymphoma, majority of them occurs in the salivary gland, parotid gland being the predominant one, while 6 to 7% we can see in lung and in the stomach, and around 3 to 4% can see in ocular admixture also. Now, various prognostic factors, epidemiological, clinical, as well as laboratory parameters have been utilized to check for their effectiveness in predicting the risk of lymphoma. We have a list of these parameters, and the boxes indicate the studies which have utilized them to check the effect of prognostic value. The green boxes are showing the positive correlationship, and the red box is showing the negative correlationship. And the factors in the upper part, those are the low level of complement, parotid gland enlargement, cryoglobulinemia, lymphadenopathy, male gender, skin purpura, low level of C3, splenomegaly, and high systemic disease activity. They have higher studies quoting them as a favorable prognostic factor for predicting the risk of lymphoma. So they are considered as strong or very strong prognostic risk factor. Now, one prognostic factor cannot put a person at a risk of lymphoma, but when they have more than one risk factor, they are definitely at high risk of lymphoma. And there are various studies which have attempted to define a synergistic risk score. And I have this is one of those kind of score which have included 7 parameters, which include clinical as well as laboratory parameters. And they studied that in a group of around more than 300 patients of primary Sjogren's syndrome without lymphoma and more than 90 patients of primary Sjogren's syndrome with lymphoma. When they found that when all the 7 risk factors are present, the probability of having non-Hodgkin's lymphoma is around 100%. When 3 to 6 risk factors are present, the probability is around 40%. While when less than 3 risk factors are present, the probability is around less than 4%. So when we see a patient of primary Sjogren's syndrome with this kind of risk factor, particularly when they have more than one risk factor, we should closely monitor them. Now, as we know that among the various risk factors which predict the development of non-Hodgkin's lymphoma and basically being the B-cell lymphoma, can the treatment with rituximab prevent development of B-cell lymphoma? So no specific study that I could found has principally addressed this issue. But from the various trials and the open label studies of the rituximab, we can have an insight in the pathogenesis of the disease. So we know that the low complement level, high cryoglobulin level, hypergamma globulin level, as well as increase in the lymphotoxin level are associated with increased risk of germinal center formation, and that can be a predictor for development of lymphoma. And also there is a unique lesion in the epithelial cells of the patient with primary Sjogren's syndrome that is known as lymphoepithelial lesion, that is infiltration of the epithelial cell by the B cells. Now, rituximab treatment has shown to reduce the immunoglobulin level, antibody level, free light chain level, as well as rheumatoid factor level, as well as level of lymphotoxin A and lymphotoxin B, and thus how they have reduced the risk of, or they have reduced the number of germinal center, and they have also completely reversed the lymphoepithelial lesion, which are considered to be the preliminary cell for progression to mild lymphoma. Next. Now, this was a prospective multi-center study in which they try to look at the, they try to compare the effectiveness of conventional DMARD and rituximab in treatment of primary Sjogren's syndrome patient. Now, the uniqueness of this is that the rituximab was given in six cycles were given, 1 gram, 15 days apart. And they looked at outcome over a period of 2.5 years. There was improvement in all the parameters, including ESTA as well as visual NRO score for the dryness, fatigue, and pain. But the important thing I want to highlight is that there is, if you can see that in comparison to the conventional DMARD, in the rituximab group, there is significantly decrease in the number of focal score. There is significant decrease in the number of percentage biopsy percentage who were initially germinal center positive, they became germinal center negative, as well as there is significant decrease in the number in the level of lymphotoxin alpha as well as lymphotoxin beta. So from these various studies and their biological effect, we can say that it may prevent lymphoma, but we have to have a proper long-term trial with a patient who have high disease activity to actually see whether rituximab can decrease the risk of development of lymphoma in primary Sjogren's syndrome patient. Now, brief regarding the treatment, as there was a question regarding how to monitor hypergamma globulinemia, there were cases of persistent purpura. So when you have multiple risk factors and patient does not have lymphoma, those are considered as high risk patient, and those patients need a close follow-up, particularly every 6 months with this basic investigation like history, examination, complete blood count, biochemical profile, beta 2 microglobulin, light chain assay. We can do serum protein electrophoresis if clinical examination put us the patient at risk of myeloma or other malignancy, serum cryoglobulin level, complement level, as well as rheumatoid factor level. And whenever indicated, we can also use the imaging modalities. Salivary gland USG. USG is now becoming more and more useful in all the rheumatic diseases. CT scan as well as PET scan. Now, if our patient is having a localized mucosa-associated lymphoid tissue lymphoma, which is seen around more than 60% patient of the primary Sjogren's syndrome, if the localized MALT is asymptomatic and patient does not have systemic, patient have low systemic disease activity, we can just wait and watch and monitor the patient. If patient is have localized mild, but it is symptomatic, still patient is having low system resistance, we can treat the mild lymphoma with low dose radiotherapy, which is localized radiotherapy. But if patient is having localized mild, which is symptomatic with severe systemic manifestation, we have an option of B-cell declipidine therapy as well as either alone or in combination with belimumab. Similarly, for disseminated mild and diffuse large B-cell lymphoma, these two are basically dealt with in collaboration with the hemato-oncologist, and they generally needed chemotherapy with or without B-cell depleting therapy. So in summary, lymphoproliferative disorder are seen in around 4 to 10% of the patient with primary Sjogren's syndrome. More common being B-cell lymphoma. Among them, the mucosa-associated lymphoma is the most common, which is seen in around more than 60% of the patient. Various risk factors or prognostic factors have been identified. Together, they can help us identify the patient who need close monitoring. B-cell targeted therapy have shown to modify the hyperactivity of the B-cell, which is hallmark in pathogenesis of the primary Sjogren's syndrome. So it can prevent the risk of lymphoma, but we need a clinical trial addressing this particular issue. And therapy for lymphoma generally depends on the subtype of the lymphoma as well as the systemic disease activity. Thank you.
Thank you, Prashant. So I think with that, we come to the end of the session. There are no questions. People are tired. So I would like to conclude regarding this session that I won't go into the individual things because we've heard all of that, but that while Sjogren's syndrome, you see 60-70% of them present with just SICA, and about 20-30% of them would have these sort of high ESRs and high globulins and anti-Ra positive and parotids, and these are the ones who are likely to go into lymphomas, and those are the ones which would may or may not require immunosuppression in the long run. But in a vast majority of patients, you actually don't need immunosuppression. That is the broad message that goes. And while a lot of research is done on that 20-30%, which there is very little research on those with SICA, and we need more and more drugs for the problems of fibromyalgia and sleep issues in Sjogren's syndrome, cortical sensitization. So with that, I think we'll come to just to answer that question regarding liftigrast. I just looked it up, and it's an integrin antagonist, ophthalmic solution 5%, and there is Opus 2 and 3 studies where people have looked at 12 weeks, and it has shown some benefits. That is to answer your question. So let me thank everyone, especially Professor Tamil Selvan for the
thank you, Dr. Sapan Panya, for your excellent. So this was an excellent academic exercise for all the DM residents or fellowship residents, and it was a very good learning experience. I also learned so many things, and it was well chaired, moderated by Dr. Sapan Pandya. Congratulations to him. And we had a long way since 6:30 or 6 o'clock. We had a long session, 3.5 hours on a webinar. Is a great thing. Congratulations to the organizers. Congratulations to Dr. Agar for organizing the things excellently. I congratulate the entire team of experts who organized the whole session. I also thank the attendees who were probably few of them left earlier, but it doesn't matter. Most of them remained intact, and you have learned a lot of experience and your sharing of your knowledge. I thank the National President, Dr. Ghosh, and National Secretary Dr. Sapan Pandya, and National Treasurer Padmanabh Shenoy for their excellent combination. And this webinar has been a grand success. I thank the coordinators for giving me the rare opportunity. Thank you, one and all. Thank you very much. I conclude this session.
Thank you, sir, for moderating wonderfully this session. The concept was by IPGMER KOLKATA, and not I came to know there are so many medical colleges in Kolkata. So this is IPGMER, with which Professor Alakindu Ghosh is the professor there and heads the Department of Technology. Thank you, all the speakers, Latika, Shenoy, earlier Professor John Matthews. Shenoy passed on that message of keeping data. You must always have curiosity. That is the message that goes. Tomorrow we have sessions on vasculitis, talk by Professor Rajeshwari and Professor Lisa speaking on lupus. I think we have important debates tomorrow too. So it's going to be more interesting stuff tomorrow, and a panel discussion by Pradyut Simhapatra. And with the message of staying safe for everyone, because COVID is on the rise almost everywhere, certainly in Ahmedabad and Delhi, but also it's bound to come everywhere. Please keep safe. With that message, I think we'll end the session today. Thank you very much, all of you, and good night.